Ladies and gentlemen, a very warm welcome to this national engagement on COVID-19 vaccination and migrants, leaving no one behind. This special event has been organized to present the key findings and launch the report based on the study conducted on the COVID-19 vaccination and migrants, which was done by IOM in partnership with UNFPA and also with technical advice and input from WHO. So during the pandemic, we have rediscovered the value of migrants, and I'm sure you all agree, in the society and for the national economy. Hence, holistically addressing the issues of migrants' health is a priority for all of us, which includes their inclusion in the vaccination program. And since the pandemic may have long-lasting consequences, it is critical for us to devise innovative initiatives towards ensuring that they remain safe and healthy. The nature of their status and mobility across the country in diverse regions makes them more vulnerable to such challenges. Please allow me to highlight some figures from the last census. There was an increase of 98% in the migrants population in Tamil Nadu state alone, with nearly 43% of the people considered as migrants. And we see a similar picture in other states too. And as we all know, one of the most effective mechanisms to contain the pandemic was the vaccination. The union and state governments need to be commended for their efforts in carrying out one of the largest vaccination campaigns in human history. It's because of these initiatives that as of June 2022, for ages 12 and above, a total of 196 crore vaccine doses have been administered, with 101.4 crore first doses and nearly 91 crore second doses and 4 crore booster doses. The fact that some sections of the adult population still remain unvaccinated, it is important for us to identify the barriers vulnerable migrants face in bringing the pandemic one step closer to its containment. Hence, while appreciating the success of the national COVID-19 vaccination campaign, IOM in partnership with UNFPA recognized the need to carry out a countrywide study identifying the key factors behind the hesitancy, acceptance, and accessibility of the vaccines amongst migrants across the country. Through this study, we hope we will have more robust collective understanding on the ways to get the migrants included in the ongoing vaccination drive. While the pandemic has disrupted the patterns of mobility and stressed the public health systems, but it is also offering opportunities to build better management frameworks. It is therefore an opportune juncture for us. What can be done to ensure that migrants are less vulnerable to such shocks in the future? Migration is a social determinant of health that can impact the health and well-being of individuals and communities. I'm sure we all know about it and recognize this significance. And response to the call to leave no one behind, which is at the core of the UN 2030 Agenda for Sustainable Development, the government and non-government stakeholders are expected to integrate the health needs of migrants into global and national plans, policies and strategies across sectors and across borders in accordance with the 17 SDGs and the respective targets. Ladies and gentlemen, migration is a dynamic process and continues to evolve over time, which makes it all the more important to formulate evidence-based practices. The sessions carefully planned across the day will help us delve deeper into these vital aspects. So thank you once again for joining on this occasion. And before I close, there is a small announcement regarding a request from my colleagues for you to please make yourself available in course of the sessions. We would like to briefly talk to you and record your quick comments on this important topic. Thank you and welcome once again.
Next, for the keynote address, I'd like to invite Mr. Shambi Shah, the UN Resident Coordinator to please address this gathering. Mr. Sharp is the UN Liaison Coordinator for India and has devoted more than 25 years of his career to promoting inclusive and sustainable development. He is also a published author of works in health economics. Prior to joining the United Nations, Mr. Sharp began his career in development with the international nonprofit Care International in Zimbabwe. He holds a postgraduate diploma in HIV/AIDS management from the National Medical University of South Africa and Stellenbosch University in South Africa. He holds a master's degree in economics from the University of Colorado and a bachelor's degree in business administration from the University of Kansas.
Dear colleagues, Dr. Muniraju, Deputy Advisor in NTIO, Dr. Pal, Economic Advisor, the Ministry of Women and Child Development, dear colleagues from the United Nations system, of course, Sanjay, head of IOM here in India, for organizing this today. Ram, Deputy Head of UNFPA, the Oscar as well, head of UNHCR, here in the audience. All of you state, senior state officials, representatives, members of civil society organizations, the private sector. It's a great honor to be here on behalf of the United Nations country team. Namaskar. Very much looking forward to the conversation this morning and the report. I'd like to thank IOM and ETIO for bringing us here together for this important discussion, bringing together so many different stakeholders in this process, and to congratulate on the launch of this very important and timely report on COVID-19 vaccination and migration. I wish also to step back and congratulate the government of India on the larger important success of the world's largest vaccination program, now approaching 2 billion doses, which is truly remarkable. And I think, the result of an incredible partnership across Indian society, of course, beginning with government leadership and government initiative, and then including the power of the Indian pharmaceutical sector, and also drawing on communities, truly door-to-door action at the community level, Anganwadi workers, ASHA workers, community members, all coming together, and it's been really impressive for me to travel around the country and to speak with people at the community levels and to really understand how this success has been achieved. It takes every single layer down to the top, and really, really impressive over the 7 months that I've been here in the country to be able to see happen. Now, and it's not just the success of the vaccination program here in India. I also wish to recognize the contribution that India has made in the international stage in terms of international cooperation in fighting COVID-19, providing vaccines internationally through the COVAX platform, and even donating COVID-19 vaccines to UN peacekeeping missions on top of that, so that they can continue their important work during the pandemic. All of this demonstrates India's true commitment to the principles of leaving no one behind, as my colleague Sandhya mentioned. Whether it's people living in remote, rural areas, refugees, migrants, people facing other aspects of deprivations. This is truly the message of the SDGs of Agenda 2030. And if we look at migrants, those who are compelled to leave their homes for whatever reasons, often economic or otherwise, threats from climate change, the list is long. There are a very complex set of barriers, and this report is very, very important for us to be able to unpack and identify those barriers that do lead to migrants sometimes slipping through the cracks of these life-saving campaigns. So the report is diving deeper and exploring these important questions around, as was mentioned, vaccine hesitancy, vaccine acceptance, accessibility to different layers and members of India's various migrant populations. I think it goes without saying that migrants are an integral part of the social fabric. And in many ways, 100 million migrant workers are the backbone of India's vibrant economy. This is something one sees when one travels around the country and appreciates the great diversity of different states. Their inclusion to shift from a problem setting to a solution setting. This really is the key. Relevance of so many of the challenges faced by migrants in health and equitable development being relevant to the broader population as well. So I think as a result of this effort, very much look forward to solutions that can really help drive broader progress in increasing health-related SDG achievements and targets on the basis of robust evidence base for health outreach. And I think, again, it's not an overstatement to say that India is the most important country in the world for the achievement of the SDGs by 2030. You can look at count up the numbers, and I won't give you a specific statistic, but maybe 40%, maybe approaching half of the global SDG targets need to be achieved in India. So if India achieves the SDG, the world has an excellent chance of doing so as well. So let me thank you again for your participation here today. I'm very much looking forward to the reports and the findings, and then of course the road ahead. All of us working together to make those findings a reality for people who are migrating for their lives, for their livelihoods, for the families, and for the country. Thank you very much for having me.
Thank you for that, Mr. Shah. We'll now move on to two sets of special remarks. Our first speaker is Dr. Muniraju SP, Deputy Advisor, NITI Aayog. Dr. Muniraju holds more than 15 years of experience in social research and administration. In the past, he has headed a state center for skill development for marginalized communities. He has also worked extensively on program management, program execution, and monitoring and evaluation of programs for the most deserving and the most disadvantaged.
A warm good morning to one and all, and respected Shambhi Shah from United Nations Resident Coordinator, Dr. Sanjay Awasthi, India Head for IOM, and Sriram Haridas, Head representing the UNFPA, and Dr. Sumant Rapal, Advisor, Women and Child Development, my colleague from the State Government of Maharashtra, from Health Department. And of course, we have representatives from Labor and Employment Departments and also Health Departments from almost like 12 states. Of course, here there are 6-7 states present, but there are also representatives from states are joined virtually, and respected representatives from the civil society organizations, and of course my colleagues from NITI Aayog. It's a great opportunity, and of course I would like to congratulate and appreciate the efforts taken by the entire UN system, because we can see large number of representatives here from the different organizations from the UN. And of course, IOM is continuously working and striving towards the welfare and empowerment of the labor community, especially the most marginal migrant workers. In fact, we had several discussions in the previous few months back about the migrant workers issues and also how to address their issues and all. And now this vaccination drive, of course, we all know that India is greatly contributing to the vaccination drive for the entire communities overall, including door-to-door survey, and we have started vaccinating below 5 children also. Now that initiative is being taken by the government. And of course, leaving no one behind is one of the SDG, Sustainable Development Goals. And of course, our Honorable Prime Minister's main focus is, we all here is mantra, the chanting for the communities, that leaving no one behind is to Sabka Saath, Sabka Prayas and Sabka Vikas. This is the major mantra he has given to all the government bodies and also civil society organizations. His call to the country is really remarkable and appreciable, and also his commitment towards the inclusivity. And of course, we know that we heard from the UN representatives that we have vaccinated almost like 80% of the Indian population. But we are mainly focusing through civil society organizations to vaccinate marginal workers, especially migrant workers. They are engaged in construction, they are engaged in some kind of street vendors, and also other agriculture laboring communities. Focusing on that, Indian government has taken, and of course the states are the backbone for the Indian government. They are continuously striving, especially the health departments and also the labor departments in the states. They are sensitizing the communities, and they are having the required human resources as well as the resources for the vaccination, and especially the funds available with the construction workers boards. That huge amount of funds are they are providing to the migrant workers, and they see not only on vaccination but also overhead development is required. And they provide scholarships to the children, they provide education, they provide other amenities required for the migrant workers. So overall, the country is focusing on the migrant workers and also other communities which needs to be vaccinated. The drive of initiatives and of course the study done by the IOM is really, it has come up with very good suggestions and strategies how to focus on overall vaccination drive. So with this, I conclude. Thank you so much for giving me these opportunities. And of course, I wish that we want to listen from the states, what the states have done and how they are going to further cover the left out migrant workers for vaccination drives. And besides that, at the concluding remarks, we will come up with more suggestions, strategies, how to enhance our vaccination drives in the country. Thank you so much.
Thank you, Dr. Muriraju. Next to be invite is Mr. Sriram Haridas on the stage, Deputy Representative of the UNFPA. Mr. Haridas brings over 18 years of experience in strategic planning and programming in both development and humanitarian projects. Prior to joining UNFPA India, he served in UNFPA Sierra Leone, where in addition to overseeing the implementation of large-scale donor-funded projects, he also coordinated UNFPA's response to the Ebola crisis.
Good morning, everyone. I'm Vidya Shombi, the coordinator, Sanjay, organizing this event, and friends and colleagues from state governments, other UN agencies, and civil society organizations. It's a pleasure to be here with you today morning. My warmest greetings to all of you. The current global estimate of international migrants stands at over 280 million. On top of that, there are also estimated over 763 internal migrants. Those are people who have migrated within their own country. So when you put together these two numbers, we see that currently there are over 1 billion migrants today in the world. So to put it in a different way, 1 in 7 persons today in the world are a migrant. So it's high time that we recognize migration, which is being driven by climate change, demographic changes, conflict, and the quest for overall economic development as a mega trend of our time. And it's also high time that it gets the importance and the seriousness it deserves. And events and platforms like we have gathered here today shows that it's finally getting the attention it deserves, at least in India. The drivers of migration are, of course, highly complex. They are specific to each country, and in the case of India, it's even specific to each state. And in fact, they are specific to each individual. They reflect a basic hope that the life will be better in a different place. A hope that often, unfortunately, reflects the reality, given the stark inequalities between countries or even between different geographic locations. At UNFPA, we are committed to addressing the drivers of migration. We strongly believe that migration should take place by choice and not by necessity. It is therefore essential that the option to remain in one's country or place, the place of choice, is a viable one for all people. Education, decent employment, fair wages, affordable housing, healthcare should be available to everyone, including to migrants. And that includes equitable access to COVID vaccines as well. We know that India's migrant workers are one of those key populations that were really affected during the COVID crisis and during the lockdown as well. We saw all the images on TV. That actually brought out the magnitude and vulnerabilities of the migrants to the forefront. It helped to create a debate and discussion in the country. So, to examine the status of COVID vaccination among migrants, we partnered with IOM to conduct a study by providing technical support to design and analysis, to draw lessons for preparedness for not only for the situations like COVID, but any future pandemic or future humanitarian crisis the country might face. I am now really happy to read the findings of the report and to see that the COVID-19 vaccination coverage among migrants is quite high. And Shambi and Dr. Muniraj already talked about that. And we should really commend the Indian government for making sure that the migrants had access to vaccines. But of course, this doesn't mean that there were no barriers for their access to vaccines as well. The study, in fact, identifies a number of barriers for migrants in utilizing different services, including the vaccination service. But I'm not going to go into details of those barriers because we do have here experts who are directly involved in the study. So they are going to hear and we'll talk about the various recommendations and various findings from the study. So I will leave it to them. And the report, in fact, identifies a number of key issues. But I would just like to take a minute to talk about one of the key recommendations which is coming out of the report. That is, for me, is the most important aspect for me when I was reading through the summary findings, which kind of stuck with me. That is the fact that there is a need for all of us to pay more attention towards women and the gender diversity in migration. As policymakers all around the world scramble to understand how migration and mass movement of people affect societies, economies, security, and sustainability, we find that the women and girls fall through the cracks. Shambi in his speech talked about how migrants sometimes fall through the cracks, but even within migrants, we fall that women are in a particularly vulnerable situation. And I will briefly try to outline you a few reasons why we need to focus a bit more on the women and girl migrants. Almost half of the migrants globally are now women and girls, and women are increasingly migrating alone or as heads of their households. And this is a trend we are witnessing in India as well. Women and girls are also now a significant proportion of economic migrants. Oscar is here today, and we know that there are many refugees who actually cross the borders. Most of them are women. So this trend, now I'm coming back to the economic migrants, represents a key opportunity for their economic independence and empowerment. The more and more women migrants we are seeing. While migration, of course, it presents opportunities, there are also risks that come as well. And there are particular risks that we feel, we see that, women and girl migrants face. We do know that, many women, and in fact, many migrants are actually vulnerable to abuse and exploitation. But female migrants are particularly at risk. Women and girls also face the additional vulnerabilities when they are displaced by conflict or natural disaster. Families under extreme hardship may also adopt coping mechanisms that jeopardize women and girls' welfare. Migrant women actually face what we call as the double discrimination, first as women and then as migrants. We often see in the global media and sometimes even in the local media some of the negative depictions of migrants and refugees. They sometimes frequently appear. On the other hand, the benefits that the migrants bring, for example, the economic contributions, they rarely make appearance in the media. Women and girls can suffer and are suffering doubly from these attitudes, experiencing not only discrimination based on their migrant status, but also based on their gender as well. So this discrimination can take many forms, including sexual harassment in the workplace, while seeking housing, while using public transportation, and while accessing education and health services. We all know that girls do not stop menstruating and women do not stop giving birth, even when they are on the move. Significant female migrants are likely to be pregnant or will become pregnant while traveling, say for example in a refugee crisis or in a high-risk situation. For example, like the one we saw during the COVID lockdown here, women may lose access to critical sexual and reproductive health services, including family planning, antenatal services, and safe childcare. So, migration, when it comes to women, it presents additional complexities, which as a group we need to keep in mind. Women and girl migrants are more likely to face health problems as well, both in transit and in their destinations as well. Even after female migrants reach their intended destination, they continue to face barriers to access healthcare, especially sexual and reproductive health services. A majority of migrants in India, as we know, they do live in cities. They do in fact face barriers to access health, especially sexual and reproductive health services, including family planning services, overcrowding, transporting challenges, and insecure housing. Yet, evidence shows that there are major returns on investing in the health of migrant population, particularly reproductive health care, such as family planning and prenatal care. I know today that we will be discussing the lessons learned from the vaccination rollout, particularly reach and coverage among migrant workers, factors behind vaccine reluctance, the hesitancy in accepting vaccines, the employer's role in the vaccine uptake. And the idea is for us to come up with concrete ways to see how the situation of migrants can be improved. However, as we start discussing and start our deliberations today, I urge all the experts and stakeholders here to look at the specific concerns of the female migrants. Their needs and concerns, as I outlined, are often very unique. By specifically looking at the needs of women and girls, who make up an increasing proportion of migrants, including in India, we must ensure the rights and opportunities at home and their place of relocation, including their right to access COVID-19 vaccination, but also going beyond that, their access to education, their freedom to marry when and whom they choose, to have their children when and if they choose, their rights to reproductive health, to be free from gender-based violence and discrimination, and their opportunities for work and leadership. And events like today offer a perfect platform for us to develop innovative solutions to the issues faced by migrants, especially female migrants. I look forward to hearing the discussions and deliberations, and also again thanking for IOM for partnering with us. And I look forward to more future collaborations with IOM and other stakeholders here, specifically building a good, solid evidence base on migrants and migrant population. Thank you so much.
Thank you for that, Mr. Vidas. We now move on to the launch of the report, COVID-19 Vaccination and Migrants, Leaving No One Behind, by our chief guests. Before we do that, could I please ask Mr. Oscar Mandia, Chief of Mission, UNHCR, to join our guests on stage. And now, Mr. Avasti, I invite you to please launch the report with our guests. Our next session now covers key findings from the report, COVID-19 Vaccination and Migrants, Leaving No One Behind, and it's co-presented by UNFPA and IOM. So I'd like to invite Dr. Sanjay Kumar, Population Dynamics and Research Specialist from UNFPA, and also Dr. Suraksha Chandrasekhar, Senior Project Assistant, IOM, to please come on stage.
Good morning to all. Thank you for the participants. It's my pleasure to present the findings of this study before you. I think that's up. Well, I think we are talking about the migrants, which is a very, very important segment of our population. And we have just put together the vulnerability they face, their size, their numbers, around 500 million, which is shown by Census of India. But actually, we try to distill those figures. What we get is all 500 million people are those who have ever changed their residence, and any time. But if we try to see whether how many of them are less than 10 years of age, less than 10 years they have done, they are likely to be more vulnerable. We found around 141 million. But again, it's a huge number. But I think this is the context when we are talking about migrants. And now I come to this study part, which we took and which we are talking about today. So giving some background of this study is that, as we all know that a very, very impressive vaccination program was launched by the government of India. It was one of the largest in the world, and also with the indigenous vaccine. And the estimates as of June this month, it says that around 60% of total population aged 18 plus are vaccinated, fully vaccinated, while 73% have got at least one dose. But at the same time, the fact remains that there are significant, around 1/4 of our adult population still needs to get vaccination. So there could be certain barriers, certain hesitancy, which actually we try to explore in this study for the migrant population. The objectives which we set is to explore the drivers which affect vaccination accessibility, hesitancy, etc. among the migrants, their knowledge, their attitude, what they think about that, what is their feeling. We also looked very closely about the gender gaps, which my colleague Ram was talking about. We try to capture those things in this particular study. And we hope that with enhanced understanding about the coverage of migrants, what are the barriers they are facing, we should be able to have better measures, not for this pandemic, but maybe in future, what assistance can be put in place for anticipated aspects in future for any other humanitarian situations. A little bit on the methodology. As we know that the data on migration is very, very limited, and it's also dated in our country. Of course, there are some attempts now to collect data on migration, but still to have a very robust sampling frame to do a pan-India study was a challenging task. So what we thought is, given all this constraint, we thought to select the 10 cities, which are million-plus cities. And as you know, these million-plus cities, they are the most hubs of those who attract migrants. Not necessarily that all the migrants goes to these 10 cities, but they also go to the rural areas and so many other places. But we thought, if we want to get some flavor of a study, so let's capture and then do this study in 10 cities, which are million-plus cities. Now, again, we know that this is million-plus city, for example, but who will know where are migrants? So next part of the methodology is that we utilize the local knowledge of those civil society organizations who are closely working with migrant populations, and with their knowledge, we try to identify clusters, and we did random sampling plus snowballing to identify where are the migrants, and we try to do the interview face to face. In all, we we could collect information from 2,189 internal migrants from these 10 cities, and we collected data online. It was a face-to-face interview. But apart from that, we also did a telephonic survey of international return migrants. So where we had a database from the network, so we did a random sample of around 700 or 800, but finally, as you know, we were able to get 103 telephonic interviews, and all ethical considerations were taken into account by it. And the period you have said that it has happened during 2 months from December to January, December 21 to January 22. There are some limitation of this method. Yes, what I said that it's a very challenging task. So first of all, what we put is one of the limitations is that in this study, we have looked only from the demand side. So what migrant says, we have not attempted to understand anything from the supply side, whether the vaccines were available or not, where, that is not a part of this study. The other limitation, as what I told, is about not having a very robust sampling frame. So that is why I think we have to put a caution about its representativeness. However, as you have seen in the last map, we actually did across the country. So at least it gives flavor of what is happening to this particular population. Now, straight coming to the findings. Let me talk about some of the background characteristics. Very interestingly, we were able to get at least 2% of our sample as a women, though it was very hard to get them, but still we got it. Their age group, if we look into, they were mostly around 65 to 70% of both men and women were in the age group of 25 to 44 years. Their educational background, if we look into, majority of them, let's say first, 1/3 was only 1/3 has a secondary level of education. Others are primary or no education, while higher education was very, very limited. It clearly shows that these migrant workers, they are semi-skilled, they are going for an informal sector. So that's another adding to the vulnerability of these population group. If we look into the employment and occupation of these workers, what we find is majority of the women, they were in garment industry, be it in Surat or Tirupur or any other place, while majority of the male migrants, they were as a casual labor. So that was the one finding. The other one is also that around 1/3 of the male, they declared themselves as a self-employed at the place of destination. It means they were working like hawkers or mechanic or something like that. So it's not that they are formally employed, but they were in the informal sector. So that's another feature of their work status of our sample population. As far as the access to their internet and mobile phone is concerned, good to note that around 91% of the male migrants, either they had a feature phone or a smartphone. The smartphones was around 60 or 61% of the male, and around half of women migrants also had smartphone access. And we inquired about if you have a smartphone, are you using internet? So majority of, or at least half of them, they say that yes, they are using internet, because these are important things when we talk about vaccination, registrations, and all those things. Now let's move out on the. Okay, so this is on the awareness about COVID among our sample. Majority of them, 98%, they were aware of COVID-19 disease. And also around 83%, they says, yes, we also know about the symptoms. It's not that we have heard about the disease, but what about the symptoms? And majority, they say, fever, cough is the major symptoms. But concern is only around half. They talked about breathing difficulties and loss of smell and other things was also less. And about what we also found that about 33% of the men and 14% of the women, they even didn't know about. Where we talked about is that we know the disease is there, what are the symptoms, how to safeguard. So that was one area of concern. As far as the sources of knowledge, what we get is that half of them they have got from the television, and probably more men got from the televisions than women, but otherwise, family, friends, and so mobile phones was major sources from where they came to know about COVID-19. When we look into the health system, putting all the messages, so it was a bit low, but it's a bit higher for males. 15% they say yes, we get to know from the health workers or health systems or sub-centers or health centers, as compared to only 8% of women. Probably they don't much go out. On the COVID appropriate behaviors, it was on the different protective measures, and probably one of the concerns was that when they go in the place of destination, the language is also a barrier. So there they express their concern, but at the same time, another 10 to 11% also said that it's very difficult to actually practice social distancing given the work conditions. So that is something we have to really see that how from the employer side we try to see that the distance and social distance can be maintained. On the diagnosis and incidence of COVID among migrants, what we found is that around half of our sample, they have either gone for the rapid antigen test or RT-PCR test. And when we asked that how many times we have undergone these diagnoses, so nearly half of these people, they say that they have gone at least once, but again, few of them, 33%, they took it for more than one up to twice, and even more than 2 times the rest of them. The reason cited by them is why did you go for this test? So obviously, if they had certain symptoms, so they voluntarily they went and got this test done. They also said that it was mandatory for them to have this test if you come for the work. So that was another reason. Also, since they are migrants, they have to move from district or state borders, another thing. So during their travel, another thing is required that we should have vaccination certificate, and to get vaccination, then only you will be allowed to go back to the place from where you had a reverse migration. So those were the reasons cited. As far as the incidence is concerned, so 96% they said they went for testing and all, but they were not having COVID positive. So it means around 3.8 or 4% of the population, they suffered from COVID. And about 12% had also indicated that not only me, but my close relatives and family members were also positive for COVID. So these were the diagnosis part and incidence. When we move around for the vaccination part, how much they know about vaccination? Also, it was quite high. It means 91% of the sample population, they had knowledge about this vaccination program. Around 86% also said that yes, we also know from where to get this vaccination or vaccines. Around again more than 90% they says yes, we also know that these vaccines are made free of cost to us. However, when we say that, when we ask a question, do you know the appropriate age of getting vaccines and all? So around 77% correctly said, but there are variations. But the concern is that around 18% they were not knowing what is the age one should get a vaccine or one should not get the vaccine. So there are certain things, and if you look into certain barriers, if you see on the left-hand side, around 17% they talk about that they were not not being able to access information to their preferred language. I was also talking about. So these things came across in different places. The language barriers and something. So I think probably not only for vaccination, but for even all the programs. When we talk about migrant friendly, so language needs to be, put it as one important factor. If you see the COVID-19 vaccination by the doses, 91% had got the first dose and 66% had got the second dose. But even if we do by gender, I think the women altogether 66% had only got the second dose, but less women as compared to men. They had gone for the second dose. We don't know what could be the possibility and factors, as what Ram was talking about, what barriers specifically females ask, that we don't have information, but we know that there are certain barriers which prevents women to catch up with the second dose as compared to their counterparts. And if you talk about vaccine hesitancy, why you were not taking and what are the side effects? So major part only came up is that either they were worried about the side effect or the experience for the first dose, or they were talking about even after getting the second dose, I would get some kind of a side effect. So this fear factor was seen in our study. Next, please. If we see that who motivated you, what was the factor behind your expectancy? I mean, you accepted this vaccination. And then we found that more men are self-motivated than women. While among women, discussions with family members, around 20%, they said their family members motivated them to go and take vaccines. And as far as the registration process was concerned, I think majority, around 35 and 47% of women and men, they directly walked into and they got the vaccines rather than going through the other processes of registering and getting time and all. And we also inquired and found out that around 81% of all the respondents, they also said that not only we, but all eligible women in our family members, they have also got this vaccination. So again, the vaccination, not only of the sample, but the family members, it also says that this coverage is also good. Next, please. Some of the factors that delayed the vaccines, what we found is the cost of the vaccines. I mean, out of pocket cost. It was free, but either they have to do an opportunity cost for that, leave the wages, or they have to travel and something. So this is around 10%. That was a barrier, and that was a delaying factor. And also around 14% that say that there are so many requirements or so many documents to get a vaccination. So they felt that these are one of the factors which prevented them to go for vaccination. And around 68%, they say that they felt that the vaccines are very effective. And on the other hand, only 8% were having no faith that, okay, this vaccine works or not works. But majority of them, it says that this vaccine is actually is helpful. And around 32% had also some difficulties in understanding instructions at the time of filling the forms and other things. So those were the other factors. Next, please. One of the things that we asked here is that about the effectiveness of the vaccines, but here we have also asked about how much faith you have in the health system and something. So again, 75% they were having faith on that, and this is also an encouraging sign that yes, they had a faith to go for vaccination with the health workers. So these were the major findings, and I think now I will invite Suraksha to talk about the recommendation.
Thank you, Dr. Sanjay. Good morning, everyone. Good morning, honorable guests, colleagues, and participants. I'm Suraksha Chandrasekhar, and I will be highlighting on a few key recommendations and action points based on the findings of this study for a migrant-sensitive and inclusive approach to improve the COVID-19 vaccination reach amongst vulnerable mobile populations. So, to begin with, the insights gathered from this survey did inform a range of specific and comprehensive outreach strategies to mobilize demand for the COVID-19 vaccine. And some of them have been highlighted here, which is that a participatory approach is very imperative with migrant workers, and also an approach that is accessible, culturally appropriate, linguistically adapted, accounting literacy, evidence-based, timely, consistent, and user-friendly key messages and information, particularly on trusted information sites, vaccine access points, benefits and safeties, symptoms as new variants have been emerging quite frequently, the risk of the disease that the vaccine itself can prevent, and the cost. So this can definitely help in building confidence and demand. And apart from that, also further having focus groups to look into their direct access to media points, smart mobile phone technology that the study has peripherally touched on, as well as other technical aspects such as signal strength, electricity, and their preferred communication channels and messengers and other information gaps that can help inform developing a tailored and curated migrant inclusive approach. An important recommendation that Mr. Sriram had indicated is looking into gender diverse and women migrants. In this study, it was challenging to ensure a gender balanced sample, but however, the 22% of women that were surveyed did provide their perspectives on the vaccine, the factors that influence their decisions, and also a few insights into barriers while getting inoculated. However, clear evidence on the specific needs of different subgroups of women, particularly pregnant and lactating women and gender diverse migrants, is important. A very important note to make is that female family members of migrant households, which the study did touch on. However, a lot more in-depth analysis is required because they largely remain invisible in most migration studies and they can easily fall through the cracks. So this is a point to be highlighted. Capacity building and training amongst relevant stakeholders such as community healthcare workers within migrant receiving states is important as well. The study also captured the important role that employers have played in informing migrants on COVID-19 appropriate behaviors and also allowing and facilitating the provision of the equipment that they need. So taking this into consideration can definitely help reach a lot of vulnerable migrants. The government of India did take commendable steps in expanding the vaccine response far and wide, complementing the efforts of the government of India, leveraging the contributions of civil society organizations is also highlighted. As civil society organizations have a good outreach with migrants and migrant communities, they can play a very important role, and calling for a concerted effort with government counterparts can help in widening the understanding of these vulnerabilities. Developing a deeper understanding on migration and COVID vaccination has been highlighted here, though we did try to reach out as far and wide as possible. There are still a couple more areas that the study could not address, such as the social processes and norms that drive life-saving resources, the quality of these services, and also the attitudes that these migrant workers receive from healthcare workers can help us also tailor our strategies accordingly. Utilizing organizational tools such as population mobility and mapping can help and support the characterization of migrant and mobile population profiles and also the major routes that are used by them. They can also help us identify the spaces of vulnerabilities that are conducive to increased health risks. So designing and implementing public health interventions, keeping in mind the subtleties and dynamics and the patterns of the mobility continuum can be very helpful. Generating a database in addition to the available country population, such as mapped migration clusters, disaggregated flow estimates, patterns of major routes, and also defining intersectional profiles of migrants and not just internal migrants, including international and returning overseas migrants, is also vital. This can help in scaling up the vaccine procurement and also allocation accordingly, in addition to facilitating deployment, planning, and capacity to address the needs of specific groups of this very vulnerable population. And with that, I thank you all for your time, and I will hand the mic back to Govind.
Thank you for those insights, Dr. Kumar and Dr. Chandrasekhar. We now break for tea and coffee, which is served outside the hall. This is a 15-minute break, so if we could please return by 11:40, that would be great. And for our virtual guests, this is a chance to refresh yourselves and return at 11:40. Oh, I'm so sorry. There was a small mistake. Before we break for tea and coffee, there'll be a distribution of gifts. Mr. Avasti, could I please ask you to give our chief guests their gifts? And I think we'll just be coming up on stage in a minute. Super. So thank you, everyone. And now we break for tea and coffee, and we'll see you back at 11:40.
चलो कनेक्ट करो बढ़िया ठीक है, अब इसको लगाऊंगा तो ब्लैक मैजिक आना चाहिए। हाँ जी, ऑडियो पे जब सही या नीचे जीरो से दो यार है। सर्च करिए क्या वही देख रहा हूँ। लैपटॉप चेंज करके देता है। हाँ कर लो, अभी तो है लैपटॉप इसमें आईपी एड्रेस खोलना, इसका कीबोर्ड इसमें लगाना पड़ेगा ना। आईपी एड्रेस फोटो खींच के डालना उसमें। ये है इसका आईपी एड्रेस। ये डॉलर 115 111 189।
Sessions have now.
Do you know who's
Around
on
nine.
the UN India team which is doing the teaching for us?
Do you know who's from the UN India team?
There's no speaker outside, no? Actually, I should ask.
ये आ गया ना ब्लैक मैजिक।
ब्लैक मैजिक
ठीक है,
कर दूं
हाँ, ब्लैक मैजिक। कम कर, कम कर। ऑर्डर प्लीज। ठीक है, ऑर्डर चेक 1 कम करो।
ये बंद कर दो।
चेक 1 चेक, हेलो हेलो, चेक चेक। चेक 1 चेक।
तू देखा तेरे पास उसके पास भी तो
चेक 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 1 चेक 1 चेक 1।
We'll now restart our sessions. The next session is called The Way Forward, Equitable Delivery, Access and Utilization of COVID-19 Vaccine Services. It's about the implementation of the National COVID-19 are from state health and labor departments, and they will tell us about lessons learned and solutions to improve COVID-19 vaccination reach and coverage amongst migrant workers. This is the two-part interaction. First, we'll hear from state health departments, and then we will hear from state labor departments. This session is chaired by Dr. Muniraju SB, Deputy Advisor, Niti Aayog, and it's moderated by Professor P.C. Joshi, University of Delhi. So I now invite our chair and moderator to please come on stage. And as our chair and moderator take their places, I also invite state health department representatives to please come up on stage. We have representatives from Delhi, Haryana, Karnataka, Maharashtra, Punjab, Tamil Nadu, and we also remotely have a representative joining from Sikkim. Again, I'd just like to request state health department representatives, Delhi, Haryana, Karnataka, Maharashtra, Punjab, and Tamil Nadu to please come up on stage. And we have a representative joining remotely over the internet from Sikkim.
I think we can invite Telangana also.
And in a small change, we will actually club the two sessions together, two sub-sessions. So could I also please invite state labor department representatives who are present to also go up on stage? I believe we might have representatives from Haryana, Maharashtra, Odisha, Rajasthan, Tamil Nadu, Telangana, Uttar Pradesh, and joining remotely, Assam.
I request Additional Commissioner from Maharashtra to please join us on the dais.
As our speakers join us on stage, I'd just like to make a request, please. The request is for each speaker to restrict their remarks to 8 minutes or less, not more than 8 minutes, so that everybody is able to get a chance to speak. Thank you. And to aid you, there are two screens at the foot of the stage. One of those screens will have a timer. So each speaker will be able to see how much time they have remaining, counting down from 8 minutes.
Good morning. As directed by my Honorable Chair, Dr. Muni Raju, I would like to start this very, very important session. Well, little bit about myself. Till not very long ago, I was heading one of the largest university of India, that is University of Delhi. So it's my privilege to be here on this very, very important occasion where we are talking of invisible population, which is generally left out. And it is coming together of UN organization, which is actually looking after all those left outs. On 20th of June, we had World Refugee Day. And today we are talking of the migrants. There is very little difference between refugees and migrants in the sense that the formers, they would be, involuntarily leaving their homes. And the latter would be leaving their homes voluntarily. That's the only difference between them. But these are very unstable populations and require a lot of care. And I'm very glad that National Institute for Transformation of India has joined together, and both of them have done a commendable job. I was going through the report, and in the report, it was very heartening to learn, number one, that of course, India is reaching 2 billion mark. And for that, even the creation of vaccine by India is a very, very unprecedented thing. I would request all of you, those who have seen this, there is a book by DG ICMR going viral, and I think you should read it the kind of efforts that have gone, because generally speaking, a vaccine which has to go through 5 stages take not less than 5 years. We had created a vaccine within 9 months. So it was 16th of January 2021 that we had vaccination drive started, and within 1.5 years, we have almost covered 2 billion. So this is great. Going by the report that we have seen, I think one very interesting thing that I saw in this report is that level of awareness was 91%, and people who were vaccinated were also 91%. There was hardly any gap between awareness and action. And this is, I think, something which must be celebrated by all of us. Now, I would like to, of course, in that efforts, congratulate all the states, especially the health departments. I know how much efforts they have made, right from Galwan Valley to Loktak Lake. They have used all kinds of transportations. They have used drones and all those things. It's really a great effort that has been done. And I think we would like to hear from the states and to celebrate this great feat that India has achieved. So I would like to request, first of all, there is a online participant from Sikkim, and I think I would request them to make their presentation. Please, I would request all of you to restrict to 8 minutes. Thank you very much.
My presentation. So it's my, could you please set up my presentation? Hello.
Yes, we are, it's audible. You can proceed, madam. Yeah. Go ahead.
I'm Dr. Shirin Doma Bhutia, Additional Director, come State Immunization Officer from Sikkim. Good morning, everyone. And I would like to thank for this opportunity here to present. And I'm very sorry we couldn't attend over there in Delhi due to the short notice and due to the bad weather. We couldn't board the flight on time. We were not able to board the flight. So I would like to start off with the presentation. My presentation. Then firstly, I would like to give a small geographical presentation of Sikkim. Sikkim is the trend-cycling state in northeast India, bordered by Bhutan in the east, Tibet Autonomous Region of China in the north and northeast, Nepal in the west, and West Bengal in the south. Sikkim is also close to Siliguri corridor, which borders Bangladesh. Sikkim is the least populous and the smallest among the Indian states. Sikkim's economy is largely dependent on agriculture and tourism. Situated in the Himalayan terrain, mountain, the state of Sikkim is characterized by Himalayan terrain. Mostly the entire state is hilly. The land of Sikkim is home for more than 200 big and small monasteries, or the Gumpas. Monastic education refers to schools run by monasteries and nunneries. There, Sikkim schools provide free education to children and currently attract enrollment for poor ethnic and migrant communities. So here, keeping this in mind, Sikkim being a very porous border, we started the vaccination for people without ID in the month of June. Then with the support of the guidelines from the GOI, we started the vaccination for people without ID, along with the people in the month of June, along with the people with ID but floating population. By the end of August 2021, we had almost vaccinated approximately 40,000 beneficiaries. So these migrants include the migrant workmen. In Sikkim, registration of laborers, workers is made mandatory for all categories of workers. All categories in the sense like the tailors, the barbers, carpenters, construction workers. Then we have the travel guides, the tour operators, drivers, photographers, security personnel included in These were all included in Sikkim in the Labour Protection Act 2005. So we took also help from the Labour Department, Panchayats and Gangtok Municipal Councillors. Then second, we have the Central Paramilitary Forces and Central Police Forces, SSB, ITBP, the CRPF. Then we have called them in batches at this COVID vaccination center and vaccinated them, keeping their identity closed. And we have the pharmaceutical companies in Sikkim. There are approximately top 21 pharmaceutical companies which provide jobs to many people from the neighboring states. Vaccination was done by the Sikkim only private hospital, that is Manipal. So we have coordinated with them beforehand so that the Central Regional Hospital, Manipal, could take up this responsibility. So we have the NHPC, the Hydroelectric Power Corporation Private Limited, in all the 4 districts. So these, the COVID centers nearby this project took up the responsibility of vaccinating the migrant workers there. And then in this NSPC hospital, we had also kept a cold chain point where the vaccines were kept and logistics were provided by the state itself. Then the monasteries, in the monasteries, we had set up mobile teams and special vaccination sessions were kept for the monks in the monastery. Then the tea garden workers. We have one tea garden worker in South Sikkim. So this was catered by the PSC nearby so that they could coordinate with the manager of the tea garden. And with that, they were able to vaccinate most of the workers in the tea garden. Then along with this, I have forgotten to mention one, that is the prisons, in the prisons. We have kept a special healthcare worker team itself in the prison area. And we made sure that all the people in the prison who didn't have the IP to be vaccinated. And we made sure that no one should be left out. So here, migration is an expression of human aspiration for dignity, safety, and as a better future. We cannot and should not stop people from migration. So along with this, we have a number of photographs. The impacts of migration before and after. Previously, Sikkim was the old photographs of Sikkim and the new photograph of Sikkim, like how the migration took place all these years. And then we have the tea garden migrant laborers image. Then we have the vaccination of the farmer companies and in the monasteries, how the vaccination had taken place and all the other vaccination that took place for the migrant workers. Thank you.
Thank you very much for your very crisp and nice presentation. You told about Sikkim, and we know about Sikkim and the efficiency with which Sikkim state is functioning. It is one of the organic state of our country. I'm very proud of you, and we are really very happy to see the progress that has been made by the state. Now, may I request, now Punjab Health to kindly make presentation. You make. Okay, you want to use? You can use that also, or.
Thank you.
Very good afternoon, everyone present here. Colleagues from the state governments, Niti Aayog, UNFPA, and other dignitaries. I am first of all very grateful for representing the State Department's work that has been a long way, starting from 2020, preparing dry run, etc., till achieving 98% of first dose coverage. Thank you for giving us a platform to present our work that has been the incredible journey and a journey filled with a lot of hope and pride for the entire country. Punjab statistics are as follows. We have covered more than 4 crore people with first dose, amounting to 98% of our population. Second dose coverage of dose 2 is 83. We still are lacking behind on the national average on the second dose, but we have done a lot of work when we try to cover the dose 1 in age 15, age 12 and above. This has been the vaccination timeline of vaccine introduction in our state as per the government policies. We started with 16 Jan with healthcare workers, 2nd Feb with frontline workers. And then we started to moving ahead with more prioritizing the other eligible beneficiaries with 1st March of 49 above with comorbidities and 60 years, 1st April to all above 45 years. At this stage, we were facing a lot of vaccine hesitancy and a lot of misinformation which had shattered the vaccination program, starting with, and then combating that, we had moved ahead. 1st May and 21st June were the times where 18 plus population were now eligible for vaccination. 2nd July when pregnant women. And then in this year, we started vaccination with our children's 12 years and above presently, and also precaution dose in the private sector. The COVID-19 vaccination timeline faced with a lot of vaccine hesitancy, earlier eagerness, acceptance, indifference, and now stands at 98% dose. The major success for this vaccination was based on governance mechanism. There was a very strong governance mechanism in place starting from the national level to the state level. The state level, state steering committee, every fortnightly were conducted by chief secretaries of our states, state task force headed by Principal Secretary Health, where it had seen representations from the other line departments and administrative heads. The district task force headed by DMs and sub-districts at the block level by STMs as well. So I think our pillar of success first goes to the governance mechanism that was in place with an active collaboration and strong intersectoral coordination. Next, coming back to the implementation phase, the success goes to the prioritization. The phased prioritization of beneficiary as per the vaccine supply had come in. We had planned this session and had managed as per the provisions that were provided in the COVID portal, utilizing them like near home CVC to reach out people at near their homes, mobile camps, and also organizing vaccination for people without identity, like nomads, prison inmates, inmates in the mental health institution, old age homes, beggars, people in rehabilitations were facilitated with vaccination using the portal. The portal had a provision to go and vaccinate them and use the center's one person identity for the other persons as well. We had launched Har Ghar Dastak 1.0 and 2.0 also in our state, whereby our health department went door to door in every village and nukkar to vaccinate. Alongside, we had also leveraged IMI, intensive mission Indradhanush campaigns as well, the polio campaigns as well, to make sure our COVID vaccination also ramps up and accelerated vaccination campaigns are conducted. There was a provision of on-site registration of the beneficiary. So we use this also so that any beneficiaries who is little ill-informed in how to get themselves registered or book appointment on the COVID portal could be, helped at that session site to get himself vaccinated. There was this user-friendly application, and it was also developed in the Punjabi language for easy increased adoption of technology for self-registration as well, which really helped us linguistically, reaching out to all the population in our state. When we come back, I want to emphasize a state initiative here that we had subcategorized our eligible beneficiaries as well. We wanted to capture not just age-wise we had also captured them as per their occupation. So we had subcategorized for registration of eligible beneficiaries The eligible beneficiaries subcategories are as follows: the high-risk professional groups like frontline workers and healthcare workers, local priority of the district at that time because we went through election, comorbid groups, industrial sector, private industrial workers, shopkeepers, student going abroad, staff work in hospitality center, Rediwara, state vendors, bus drivers, auto drivers, jail inmates, even those who were comorbid, and other PRI representatives were also categorized to capture the occupation-wise take-up in our state. And we have the number, around 10 lakh people were subcategorized in our portal, COVA portal, which was primarily designed for COVID-19 pandemic. Second was the mobilization of beneficiaries. I think that played another very important role by CSOs and NGOs for developing community awareness, addressing vaccine hesitancy, eagerness, countering the misinformation, mobilizing people around, and also supporting operations at the vaccine site. This collaboration with the CSOs and NGOs helped us to reach out every single person. Relevant partners and stakeholders like NYKS, NSS, Red Cross, Mamta were approached. Incentives for ASHA for mobilization was a very important tool and a strategy which helped even to keep our healthcare worker or the human resource motivated to conduct such a large scale and amount of work that they had to do. Facilitated cohort registration was also done to facilitate the registration of people who are coming and their technical adoption of the digital platform. IC activities throughout the vaccination program and its implementation, it went through a lot of phases whereby we had conducted. At this time, our center of giving the information was a strong IC at every place. You know, we were receiving phone calls by Amitabh Bachchan as well. There were hoardings all around. There were e-rickshaws. Gurudwaras were also utilized for giving IEC activities in our state. They were specially due dose reminders were sent from a Punjab state health agencies as well. There were calls made from the helpline numbers to reach out to every beneficiary and to seek out why they are not coming for their second dose. We had the list of the beneficiaries who had received the first dose. We utilized that list for that. Advertisement of CVCs as well in newspaper and other social media helped them to connect to their nearest CVC as well. Collaboration and partnerships. Yeah, I'll take 2 minutes more if you allow. Yeah, collaborations and partnerships are the strong pillars and our foundation for this success that we have reached today, especially emphasizing the Radha Swami Satsang, the Gurudwara, the Pharma Cooperative, the foundations for transgender, border security, even professional bodies like IMA, Indian Medical Association, FOXY, Rotary Club, Nirankari, and even industrial-based sector like PepsiCo and other factories had also helped us to this picture depicts the success stories. Now is the time for the pictures from our state. As the time is very short, I've selected only few. So first success story that I believe is motivation of the human resource who is doing this, tiring work day in and day out. Sunday, be it any national holiday, COVID-19 vaccination camps were organized. So our state did an appreciation to all the officers, and there was a celebration of 100 crore that helped us to even take our vaccination further. Engaging religious groups like Radha Swami Satsang, who had not just supported us in mobilization, but also given us session site and also some hampers for the people who were mobilized. The success story of vaccination, not just door to door, but also in mandi and in shops as well, because they needs to be protected for COVID-19 pandemic. Har Ghar Dastak, where we reached out to every beneficiaries. It was not a simple task. The vaccine needed to be carried, to be safely carried in a cold box at right temperatures and delivered and inoculated with adequate safety precautions. The special vaccination on wheel strategy helped us to reach people, and then also side by side we had doing their registration so that they receive the SMS as soon as they get their vaccination. Trainings. Most of the trainings when the vaccination
I think you
rollout
should conclude
started
now.
with
There are
physical-
certain things
okay.
that, you know.
That the unique
So
story.
first of all, no, please. It's okay with
done.
you.
Thank
So
you.
first of all, I would like to congratulate Punjab State for doing such a dynamic work. And I think, yes, that's very good. And 98% coverage actually is very good sign. And but then Punjab is also known for migrant workers and especially people coming for agriculture. You know. I was looking into your figures. You know, you had mentioned about private industry people. What about migrant worker? Were there some strategies? Because you gave us a general idea about how you covered. But were there some special efforts made for the migrant workers, those who are working in the fields? Agriculture workers particularly.
I would partially answer that, and I would partially ask Dr. Rakesh also to comment on it. We had industrial workplace. Oh, sorry. Yeah. So we had industrial workplace CVCs made for the industries. For the migrants who were reaching out for the agricultural work, the community facilitated them to get them vaccinated. When the migrants came back, they came back with first dose either in UP and Bihar, as majorly they come from those states. We had made sure that they receive their second dose when they, come in our state. So yeah, I think the platform COVID also helped us. There was a uniformity. So with just using their phone numbers, we could give them the second dose at our, and that was ensured.
Okay, thank you very much. Thank you very much.
We love to hear you, any constraints you have faced during the vaccination drive, so that any changes we can bring in our policy framework, any bottlenecks or difficulties, constraints, that also we want to listen and we can.
Absolutely. I'll discuss them. I think we'll give to
In the next
phase and then
second round, we can have a.
Thank you very much, Punjab. Now I would like to invite Dr. Puneet Jetli. Just a second. You want to say something?
Speaker, I have seen slide. They said 10% of the migrant in Ludhiana. And sir, Ludhiana, we did first dose 110%. That means we covered all, and we make a strategy with the Deputy Commissioner, Labor Department, and Industrial Department, all set together, and we organize camp in each nukkad and industry. And cover all the migrants.
Very, very good. I think a lot of lessons have been learned, and I think Niti Aayog is here. So, and especially constraints, we would be very much interested in all the participants. So, Dr. Puneet Jetli is actually from state immunization. He's a state immunization officer from Delhi. So, he'll be representing Delhi state. I would request you to now make your presentation.
Good afternoon, everyone. On behalf of the state, I'm very thankful to the August gathering and for giving us the chance to share our initiatives and achievements. First of all, there were few concerns which before starting the presentation, I would like to answer. The elite class, the elite migrants are able to take care of themselves, but those migrants who are staying in juggies, working in factories, are homeless on the road, the beggars, living below the bridges, those were our concern in Delhi. And those were the people whom we had to focus extra. Regarding women, definitely we had extra pink booths set up in all the districts of Delhi and dedicated to every one of those who were not able to create a slot for themselves and could get them vaccinated, even at those periods when the getting slot for vaccine was very difficult. Regarding affordability, precaution dose is not available for free in most of the states for 18 to 9 years of age. But thankfully, Delhi has started this drive and we have made it for free for everyone, poor or rich, for everyone who's taking the vaccine. And Delhi government is reimbursing to Government of India for all those doses every fortnightly. Let me go through. So Delhi is proud of its achievements so far. We are very proud of our numbers. As we can see that we have achieved 111%. That means the 11% extra were the migrants who have taken first dose, and most of them must have taken second dose in their respective states. Similarly, second dose, we have achieved 95% so far. Rest of the 5% have migrated to other states and may have taken the dose with some other mobile number, so it is not getting reflected. But our teams from districts as well as in the field are constantly calling all the due and overdue beneficiaries, and we have noted that few of the beneficiaries are no longer staying in Delhi. So that is the deficit here. Regarding 15 to 17 years age group, the Covaxin which we are giving, we have achieved good numbers, 98% first dose in schools, then 83% second dose. As soon as the school opens, we will cover the deficit and we will achieve 100%. As far as 12 to 14 years, similar is the thing. Massive COVID-19 vaccination drive started. We were caught red-handed. We were not prepared initially. We never had such a huge drive. We were vaccinating from 0 to 5-year children and very less figures above and over and above that. But suddenly adult vaccination to the tune of 148 lakhs, 18 plus population, that's a huge number. And we had to do a lot of things which were unprecedented. Lot of sites were set up in the dispensaries, in the RWAs, in the education, in the department, that is schools. Schools could provide classrooms because it was the absolutely lockdown period, and schools were vacant. So we utilized that opportunity to vaccinate as many people as we could. Regarding cohort of 12 to 18 years, we chose to vaccinate them in schools only. So micro level planning were done by Ashas and Anganwadis. We started with Jahan Vote Wahan vaccination campaign because our voter list included everyone over 18 years of age, and we could hold the session at the voting places nearby their residence only. And our booth level officers were mobilizing beneficiaries to those voting centers, and we could achieve the numbers there. Regarding dedicated sites for people with disabilities and home delivery agents. So these are the people, home delivery agents, which are mainly migrants. So every delivery boy, we vouched for vaccination of every delivery boy in Delhi. For that, we opened district-wise dedicated centers where they could just walk in and get themselves vaccinated. And I am talking of those times when the arrangement of vaccination slot was very difficult. We had mobile bus vaccination, vaccination on wheels, drive-through vaccination, near-to-home vaccination. In RWAs, we organized a lot of vaccination centers, dedicated centers for pregnant and lactating women. Uber arranged free transportation up to 150 per ride for everyone who could not afford transportation. Our chief minister is always a major influencer and always raising voice. So these were some of the IECs which were displayed in Delhi. Every organization inclusive of DMA, OBS Gynae federations, those were involved in various IEC and percolation of message down the line. Some more initiatives. We had IEC in all the most of the main languages like Hindi, English, Urdu, Gurmukhi, that is Punjabi, which people understand here, and dedicated centers for disability, dedicated centers for international travelers, dedicated centers for delivery boys, dedicated center for women, dedicated center for housemaids. Housemaids, a lot of migrants work as housemaids here. IEC campaign, counseling mobilization through Ashas, Anganwadis, mobile vans, especially for Jhuggi Jhopdi clusters, especially for market areas. Those were our forte. Left out beneficiaries. This is very important. All the left out beneficiaries were searched for in the field by Ashas and Anganwadis, and they were mobilized and vaccinated then and there. And we had focused difficult to reach areas by mobile vans, as I already said. Civil defense volunteers, NGOs played very important role. Religious leaders, those were involved. Facilities, we vaccinated a lot in mandir, masjid, gurdwaras. This has already been covered. Efforts for homeless. This is very important. We had a lot of vaccination under the bridges, by mobile vans, we hired battery rickshaws for this. These are some of the pictures. Local influencers, councillors, MLAs, once they took vaccine, everyone came forward for vaccination. So as we can see, religious leaders also, once they took vaccine, everyone came forward. This is our vaccination on wheels. We have the buses in which we carry out vaccination, not only for elite class, but to most deprived class. We position these buses outside the JJ clusters in the markets, and we get everyone vaccinated. Definitely migrant labor getting vaccinated in factories. We target each and every factory via market associations, and we have achieved good numbers through this drive. State steering committee meeting under chief secretary, state coordination committee meeting under principal secretary and secretary, and a lot of state review meetings have taken place to achieve this number. Har Ghar Dastak 2 campaign, we have reached now. The beneficiary is not coming to us. We are going to beneficiaries, and we have been able to achieve a good number of precaution doses also. Battery rickshaws being used for vaccination, and tents set up outside ISBTs, which are the main centers for migration, outside the railway stations, in the masjids. We have used a lot of battery rickshaws for vaccination. This is special vaccination center for battery rickshaws. Some mobilization drives going on, school activity. Thank you. Thanks.
Thank you very much for sticking to the time.
I was looking at
yes, yes. I think it is again a matter of celebration that Delhi has done a very good job, and especially your efforts and the whole state machinery and the bureaucracy. I think everyone was involved, and you were reaching 111%. That's very good, because migrant laborers is a floating kind of population. It's very difficult to chase them. But still, we would like to know, if there are some bottlenecks, if there were some difficulties, and if you had made some special efforts to, meet those challenges. That would be a great lesson for all of us.
One very important bottleneck initially was availability of vaccine. Vaccine was not available at a pace at which we were vaccinating. So every now and then we were going absolutely bankrupt as far as vaccines were concerned. So Delhi purchased a lot of vaccines initially when it was not been provided by Government of India directly from the manufacturer. So this was one initiative which we did. Another initiative that people were not coming forward for the third dose, that is precaution dose, because it was not free. So as I already said, that we have made it free for everyone from 18 to 59 years age also, and we are reimbursing Government of India for those doses which we are administering to this population. So these are the two initiatives which have more or less compensated for all the bottlenecks.
Well, I must say, creating so many, manufacturing so many vaccines, it's such a short time. I must tell you that when penicillin was discovered in England, they were not ready to, produce it. So the foray has to go to America to get it produced, and that made a difference in the Second World War. I think nearly 15% of people's lives were saved. Similarly, I think because of this aggressive way in which the vaccination has been covered in India by different states, Lancet has said that nearly 42 lakh lives have been saved. 42 lakhs is a big number that has been saved. So again, I would like to congratulate all the states who have really done wonderful. Thank you very much.
Thank you.
Now, I would like to request Dr. Manivelan from Tamil Nadu. Vinay Kumar. Okay. But what is this? Okay, please.
Can I start, sir? So good morning to everyone. To just start my presentation, I've just extend my sincere thanks for the organizers to giving an opportunity to make my presentation over here. on the lessons learned in COVID vaccination. Because this is episode we are doing for last 2 years. Since we started in 2021, we are doing, still continuing. So just thank the organizers for giving this time for sharing our experiences. So since I've been given a time of 8 minutes, I'm just running the slides because I thought of giving a briefing about my COVID status in Tamil Nadu, because right now Tamil Nadu is reporting more cases, more cases along with Maharashtra right now. So I thought, but I can skip those slides and go directly to the vaccination part. So we face the 3 waves, and these are the positive cases, deaths and all. I just skip all those things and directly go to the vaccination part. So vaccination is nothing new to any country. Of course, India also had many vaccines, not from the COVID vaccines, but also we had all the routine immunization vaccines, which were giving 19 doses for an infant of 1 year and 23 doses for a children of 2 years. So nothing new for India on vaccines. So these are the vaccines which already my previous speakers dealt about all the COVID vaccines, and our moderators are also just saying about how vaccines were made it very in a short period of time. So just skip all the slides. And this again may explain my Punjab counterpart about the episodes when we started all these vaccinations. So for Tamil Nadu, every way when Government of India guidelines are issued, we immediately start the next day. We are not waiting for the 1 week or 2 weeks. There's a lot of sincere political commitment in the state of Tamil Nadu, and we're doing it immediately. And so we all revised everything. Even for the pregnant women, it was approved on 2nd of July. We started immediately on the 2nd day itself. 3rd of July itself, we started. Government of India permitted on 2nd of July, and we started on 3rd of July, immediately with all counseling part. So all these things says about how we started the vaccination events and all. So to say about finally, about in the world globally, we have this number of doses been given at present. And today till morning, we have 16.5% total India doses been covered globally. There is till now we've done 196 crore doses been given by by our country, and this contributes about 16.5% globally. So this is the status of COVID vaccination performance of the state, given the breakup based upon the vaccines available with us. And till now we're done with 11.37 crore vaccination doses given to the beneficiaries, eligible beneficiaries above 18 years, 15 to 17 years, and 12 to 14 years at present. So this, I just want to make a slide over here, because initially when I was telling about the vaccination part, Tamil Nadu, though we with other states like Maharashtra, Kerala, and Andhra and Telangana, we share the best indicators in the health department. But we had faced the heat of vaccination in Tamil Nadu, because everywhere in the reviews that with Tamil Nadu in the last 4 states in the perspective to the vaccination, because the main point is about the initial pickup of vaccination in Tamil Nadu was not very much expected by the Government of India also. So the initial, you can see the slides from January 16 when we started the vaccination till May 7th, it was only per day average about 61,000 vaccinations per day. But after that, May 8 to May till June, till yesterday, it is about 2.57 per day doses we're giving. So this is a massive improvement in the per day dose vaccination. That's mainly because of the people movement. I'll just explain the part in the later part of the slides. So this is the day coverage, and now you can see the maximum we happened in the month of September 2021, and now it's coming right now to 93,000 doses. So these are the statistics of my presentation, of my vaccination. So first dose about above 18 years, about 94%. Second dose about 85%, and 15 to 17 years we covered more than 89% and 73% second dose. And 12 to 14 years, we covered more than 84% of the first dose and 53% of the second dose. Rightly, as my Delhi counterpart said, that the schools have been closed till now for the May vacation, and now it's been open. So we're doing a school vaccination campaigns to improve the school vaccination with Corbevax. So next, and these are the challenges what we face in vaccination in Tamil Nadu, because I told it's vaccination is voluntary. So in Tamil Nadu, of course, we share the literacy rate very good compared to Kerala also. So many people said that why we need to get vaccinated. So we can't able to make them, although there is all easy activities, everything we're giving them, but there is some issue that saying vaccination is voluntary. So we face this heat of being a voluntary vaccination. So we had to target those beneficiaries also. And then the episode started as vaccine hesitancy. Then it converted into vaccine avoidance. Hesitancy is, why should I vaccinate? I don't want right now. Vaccine avoidance, right now, no, COVID is not there in Tamil Nadu. Why are you asking me to vaccinate? So that's turned into vaccine avoidance period. And finally, we had this adverse events following immunization. And Tamil Nadu faced a biggest heat in these adverse events, because one of the famous comedian I think some people know his actor Vivek. He expired the next day after vaccination. That had a lot of impact on the entire vaccination. The entire month it was drastically reduced to minimum of 1,000 doses, 10,000 doses per day. And then of course with the media hypes and all. Next, these are the few challenges and how we overcome it. So first is a workplace vaccination, which been explained by counterpart by Punjab also. We industrial vaccination. We made a specific sessions industries linked to a private hospital. It says Apollo Ford industry. So this we worked with the coordination of the joint director of DISH, this calls the district industrial office in the every districts they'll be there. And we opened with the dialogues with them and we coordinated the sessions over there. The two things I just want to highlight over here is the CSR funds. We tried to get the CSR because initially when there is a shortage of vaccines, when government of India permitting private vaccination, private hospitals to procure vaccines, we turned into as a CSR activity. Let the Ford company sponsor to 2 lakh rupees, 20 lakh rupees. Apollo Hospital buy the vaccines and vaccinate this Ford company migrants or Ford company laborers who are working in the Ford companies. So we targeted those approach, and again we implemented the Tamil Nadu Public Health Act. It was public one of the oldest act in 1939. We just made it the other way around, not as vaccine mandatory. We made the people or the organizer of this, even the hotel, those who enter the hotel should be get vaccinated. We never made vaccine is mandatory. Whoever want to enter the hotel, ensure that they are vaccinated. But ultimately, this was there for about 5 months. But ultimately, because of the Supreme Court judgments and all, we had to withdraw this notice again from the issue. And of course, migrant laborers, I have my sincere challenge here because in state of Tamil Nadu, we still have not a proper database of the migrant laborers. These are data available with the industries department. I just got this for this migration activities. And of course, disabled persons, we have the database. So this is a mega vaccination camp is again a major success where we targeted the migrant laborers, all the people, because especially when the new government took over, we targeted this mega vaccination camps on every Sunday because it started in September 2021 and we are in June. Till now, we've done 30 camps. Of course, the total Sundays will be about 36 Sundays, and all the Sundays we are having camps on this mega vaccination, mainly to target the migrant laborers and those left out vaccinations. So door to door, it was explained by Hardadas campaign 1.0 and 2.0. These are the beneficiaries. And school vaccination, we have the RBSK teams and MMU teams. We have more than 770 RBSK teams with us and 462 mobile medical units. Everyone were deputed for this school vaccination camps. Because of this, we're able to hire 90% more coverage in 12 to 14 years and 15 to 17 years. And finally, I just want to put a word is vaccine equity. And this is a word which we are targeting on the migrant people also because it's a pan-India program. And a person from Bihar will have to come to Chennai for work. He has to get vaccinated. We are taking care of them. The only challenge for me will be, and of course, this I'll explain later. And finally, to conclude, it's the fastest way. And the only thing is, no one is safe and everyone is safe. We don't segregate as a migrant labor. Anyone who come to Tamil Nadu, they are treated as another citizen because anyway, they'll be spending time with our people also. So we continuing our efforts in vaccinating the entire thing. And finally, a word. These are my pending, but this for our general appeal. And finally, to say this, no one is safe until everyone is safe. And thanks for this opportunity.
Thank you very much. Thank you very much. And thank you very much for a very nice presentation and especially highlighting the issues and hindrances and barriers which you faced. I think South states are a matter of concern for all of us. And not that they are not vaccinating. Maybe the virus is behaving very erratically in those places because of the other factors. But I'm glad that you have made great efforts, and I think the state government has done all that was possible. So I would like my friend to add to it. Yeah? You want to add something?
I have one more point of challenge before you ask me, sir. The problem for me in our state is, because of course, don't mistake me, even when we're able to follow up the second dose due beneficiaries who have come over to Bihar or Uttar Pradesh or Delhi, the language is a barrier for Tamil Nadu because hardly we speak Hindi. So even if I am able to understand Hindi, my second health workers and all not very much fluent in Hindi. That's a barrier also for me to follow up the cases.
Thank you.
Thank you. So just to add to
add briefly.
Yes, sir. Yes, sir. The migrant workers, especially from interstate migrant workers, were covered by the labor MMU that was sponsored by the Construction Workers Welfare Board. We have got one van for the one state, and in Greater Chennai Corporation, we have 15 zones, and each zone has got a one van. All these vans for really 1.5 years have been pressed mainly for the vaccination. Point number one. And the other part is these vans will go to based on ATP, Advanced Tour Program. And in some places or in most of the places, they even went to the labor camps also where the unorganized workers are staying. So the industry part, as he mentioned, Department of Industrial Safety and Health are covered by the organized workers by the companies, either using the government funds or the CSR funds. These unorganized workers, mainly the construction workers and the other people who are in Tirupur and various other people were mobilized by the NGOs and the trade union leaders. So how I know is we have a separate department in the government of Tamil Nadu to take care of the health and safety of the unorganized workers of the entire state.
Thank you. Thank you very much. And now it is my privilege to invite L. Chaturvedi from Telangana. Am I correctly pronouncing? Okay, please. L. Chaturvedi is from Labor Department.
Labor Department.
Okay. Okay. Okay.
Sir, I will restrict to the vaccination part because we have from Labor Department side, we have taken all maximum welfare measures to the interstate migrant workers. So we have contact the health department, director of health department contacted labor department to identify the migrant workers. So immediately our officials instructed all field functionaries to identify the interstate migrant workers. We have concentrated on bricklanes. Mostly bricklane workers are from Odisha state, sir. So there are 719 bricklane establishments are there. And we have directed all my ALOs and other peoples to involve, identified, and we have collected numbers and everything. And we have furnished the data to DMHOs of the districts. So immediately camps are formed and 180 mobile vans are constituted, sir. And even the medical and health department issued one GO number 58, where 4 types of task force are formed at a state level, at a district level, at mandal level, like that formed, sir. And NGOs are involved, labor department officials and other department officials also involved, sir. Our state has involved all stakeholders, all departments in this matter, sir. And we have concentrated on bricklane workers, sir. And the mobile vans went there and they are vaccinated. And in Telangana, a lot of construction works are going on, sir. And we have identified the factories, construction, and most of the interstate migrant workers are employed in rice mills and other areas, sir. So we have concentrated and we have asked the employers to facilitate, appoint facilitator for the vaccination of that employees. And our enforcement duties will issue licenses to the contractors. And we requested the contractors. So all migrant workers must be vaccinated. We have given instructions, sir, at the time of approval and whenever any meetings are going on, and we insisted, sir, first of all, you vaccinate your workers and then come with the certificate. Like that, the vaccination process, because I don't have the entire data of the medical department and mine, sir. These are the ground realities I am telling, sir. During the course of my official duties, I had opportunity to meet the HR people of the Bharat Biotech, sir. So in that, I'm interested in this vaccination of this thing. I would like to take the help of that thing. And they have told me, sir, the Bharat Biotech is located at Rangareddy district, Shamirpet area, which are employed 1,000 people, and they are rendering good service for production of vaccinations, sir. Recently, they have invented nasal vaccinations. That is in the 4th stage, and clinically it is proved according to them, sir, and which is low cost. And these nasal drops can be poured by anyone, and we can use that vaccination, and we can utilize the services of the Anganwadi teachers and ASHA workers, and so that more vaccination can be done, sir. This is I would like to put forth to you for implementation, sir. And in my Telangana state, sir, what I observed, so many NGOs, they are involved, sir. They filed bills in the High Court, sir, for the implementation of labor laws as well as for the vaccination of the interstate migrant workers. A number of bills were filed. Our Honorable High Court Chief Justice and other bench, sir, from time to time, they are monitoring the status, sir. So judiciary also actively involved in it, sir. That is good thing, sir. And when judiciary is involved, we effectively worked in the field area, sir. We asked our subordinates to be in the field for vaccination of the workers, and we insisted like that along with all stakeholders, sir. This is one thing. Even police department also played key role, sir. And during the COVID period, and in the rehabilitation of the migrant workers to their native places, and the Telangana government constituted help desks and vaccination centers at railway stations and other prominent areas. And even while repatriation, as per the Honorable Court High Court directions, we have established rehabilitation centers nearby the Secunderabad and the Nampally railway stations, and where the doctors are deployed. And we have taken care of the women migrant workers, lactating mothers, and we have utilized the services of the ASHA workers and medical staff, sir. These are the ground reality from the Telangana area, sir.
Very good, very good. And I think because the immunization department is not represented, so we do not have the exact figures. But the way, huh? You are there. Oh, you want to say something? But you should have said within 8 minutes, you know. So you have got 2 minutes now, please.
Thank you.
Oh, okay. So he's different, right? You take your 8 minutes. You now give us a good picture of Telangana and their health department and what they did, because you are a separate department now. Okay.
A very good afternoon to all the dignitaries on the dais and off the dais. I'm Dr. Sudhira, State Immunization Officer and Additional Director for Planning in Telangana. So as all the speakers have said, we have started the COVID vaccination on January 16th officially in our state, as per the directions of Government of India. But our preparations began almost a month before that. Since this workshop is basically pertaining to the migrant workers, I'll just quickly brief you. Actually, we were informed yesterday night, late night, so I could not make any presentation for you. But I'll just quickly take you through all our activities. And I'll also give you some performance and our data also. So to start with, I would like to mention that Telangana, as of yesterday night, 9 o'clock, we have administered around 6,39,34,296 doses as per the COVID portal. And we have around 1,000 government vaccination centers, stationary vaccination centers, and we have around 1,300 private vaccination centers. However, the coverage was more in the government sector. And when we looked at the government coverage, it was 5,95,77,000, and the private sector was around 50 lakhs. It is around 43 lakhs. We have followed all the guidelines of the Government of India, and as and when the government has directed us to take up the various age cohorts, we have taken them up immediately the next day. And the highest authority, our Chief Secretary he was spearheading all the activities, and under the leadership of our respected Chief Secretary and our respected Secretary Health, all the district collectors and the DMHOs of all the 33 districts. As you all know, Telangana is a new state reorganized in 2014 from Andhra Pradesh, and we have 33 districts. And all the district coverages for the first dose are 100%. There is no district lagging behind. And the 2 days back data, I have not taken the latest data for comparison with other states, but among the larger states, we have done 100% for first dose as well as second dose. For the first dose, all the 33 districts are 100%. And when it comes to 15 to 17 age group, we are at 97%. And as the schools and colleges have recently reopened on the 13th of June, we envisage to cover all the beneficiaries. We envisage 100% coverage in the next 15 days. And for the 15 to 17 years second dose, we are at 87%. And for the 12 to 14 years first dose, we are at 90%. And this also, as the schools have recently reopened, we are in conversation with the Secretary Education, and we are having a plan of action wherein in the next 2 weeks, we will cover all the private sector schools. This was the lagging because private sector, they had exams, and then we had some constraints which we could not do in April, May. Now coming on to the second dose of 15 to 12 to 14 years, again we are at 70%, and all these we are going in a very planned manner. And for the precautionary dose, as the other states also have mentioned, we have a little kind of a hesitancy since there is a downfall in the cases, but still we are doing all our level best. And to have maximum coverage and to ensure, we had wonderful convergence with all the line departments, wherein the Education Secretary, the Panchayat Raj Secretary, the Municipal Administration, and the concerned ministers, the honorable ministers also, we used to have reviews with the district collectors and DMHOs on the other end, and the secretaries and the ministers of the various stakeholders were totally taking charge of the program. And to facilitate the migrant workers, especially when we started above 18, there was a huge surge, and there was a lot of demand for vaccine. And there was a lot of gate crash. There was a lot of panic because everyone wanted vaccination on, immediately. Everyone wanted, because once the government announced vaccination for above 18, everyone was in a panic kind of a situation. And then, as per the directions of our Chief Secretary and Secretary Health, we came out with a strategy where we identified 45 groups of beneficiaries based on their occupation and profession. And accordingly, we came out with a strategy to vaccinate them on priority. That is inclusive of the migrant workers and all the labor population. We have interstate and we also have intrastate. So as Hyderabad is a mega city, you all know, with a population of 1 crore and lots of migration in from the neighboring districts of our state and the neighboring states as well. And also the fast developing Hyderabad, lots of construction sites, lots of malls. And when we look at the occupation of the migrant workers in Telangana, basically, the women migrant workers are basically household helps, cooks or small time tiffin centers and hotels. They do domestic help. And also they are placed as watchmen and help at apartments and housing societies, and also petty vendors and fruit and vegetable vendors. So we had a kind of an action plan at the mandal level, at the facility level, so that each and every village, these people were actually line listed by the concerned medical officers, and they were planned specifically on days, and each team went to their doorstep, so that, as was told by the earlier speakers, the migrant women and children are especially vulnerable because they are left out at home. So we took vaccine to their doorstep, so that we do not, cause any kind of an out-of-pocket expenditure for them. And at the same time, they are provided vaccine without any wage loss. We went to their doorstep at specific times, early in the mornings, later in the evenings, so that they could take vaccination and then later go back to their various job course or their labor work. And also, we cater to the physically handicapped and the old people, where they are left out. If they have to come to the vaccination center because of their immobility or they need some support, they will not be able to come. So to ensure equity of vaccine distribution and vaccine administration, much before the government has announced the Har Ghar Dastak 1.0, the state took up vaccine at the doorstep. So there in the habitation and at the village level, we had two teams. One team was the vaccination team, comprising of the healthcare department or the health functionaries, staff nurses and ANMs and ASHAs. And the second team was the line departments, ward members, sarpanchs in the rural areas, and corporators, local leaders, and influencers. They formed the mobilization team. And accordingly, these people at a strategic location, sessions were planned. And in certain large villages and habitations, we had more than 2-3 session points, wherein the mobilizers mobilized the non-vaccinated and those due also to these session sites, and we ensured that all of them got vaccinated. And also to reach out to these student migrants from other countries.
Conclude, please.
Yeah, okay, sure. So we reached out to them through the COVID portal and put them as priority group. And we ensured that all the migrants also were captured. And as already mentioned by the labor department, we had 200 mobile teams. And lastly, I would like to mention, we had 3 24 hours COVID vaccination centers in the city of Hyderabad, so that they could come at their convenient time, wherever they are. If they are working at morning or night shift, they could come. Any beneficiary was having the comfort and facility to come at their own convenient time, and press and media was very supportive, so that all the issues, even AEFI or anything, it was talked very openly. And Telangana has done wonderfully well. And I would conclude thanking the organizers for giving me this wonderful opportunity to be at this forum. And I'm also thankful for being a part of this largest vaccination campaign in the globe. Thank you.
Thank you very much,
Dr.
Sudhira. She's the Assistant Director, State Immunization Office. Please. I think Telangana is a very good example of coordination and cooperation between Labor Department and the Health Department. And I think, like you said, you have done very well. We would like to congratulate your state. 64 million vaccinations is not a small task, and that is very good. And I think you have been able to get 100%. Then for 15 to 17, 97%. And what I like most was that you want to complete your target within 15 days. And I think that's a mission that you should take up. And we are very happy to have your experience here. Now I would like to invite Dr. Sachin Desai, who is from Health Department, Maharashtra.
Good afternoon, everybody. I thank the organizers for giving me the opportunity for the presentation. At the outset, I will tell that the state of Maharashtra had administered more than 70 crore doses till yesterday. Out of that, 9 crore doses were the first dose, 7.5 crore were the second dose, and more than 35 lakhs are the precautionary doses. So, and also in the month of September, we had administered more than 10 lakh doses in a day to the beneficiaries. Second thing is that in the COVID, there is no such category as we can label as a migrant. So initially, we don't have any data, specific data regarding how many migrants had been administered the COVID vaccination. But the figures like 17 crores can tell that we have very good covered the peoples or the migrant population also. Coming to our specific topic, that the migrant population, as we know that the Maharashtra is the industrialized state, second most populous state in the country, having GDP 14% of the country, and well known for the inter or intrastate migration. Specific to coming to the migrant population, with the help of Government of India, we had one of the partners, JSI India, who had come for the support of the COVID vaccination. And with the help of the JSI, we have identified more than 4 to 5 NGOs who are working in the field of for the migrant population. The names are that PCIF, MGVS, HelpAge India, YGR, CARE. These NGOs are now working in more than 19 districts in the state, and majority of working in the field of this migrant truckers and the vulnerable population. The major of these cities are on the national highways, and that's why we have asked them to work on this national highway so that we can tap this migrants as well as the truck drivers and the loaders. The activities carried out for the vaccination of this migrant or the truck drivers were involvement of the key stakeholders for this population, then implementation of the BCC activity so that they can be asked for the vaccination, and that will help for the increasing the coverage of the vaccination. Then conducting the sensitization as well as the capacity building workshop with the industrial partners where these migrant people work. Also carrying out the mid-media strategies at the intervention site, like pictorial approach, announcements, street play, jingles, IPC sessions, and conducting the mega camps. Special vaccination camps were also arranged for the migrant population for these peoples. Then hub points were also the halt points, or the specific points were also identified for this migrant population so that they can be approached at the specific points and they can be tapped there and the vaccination can be done. Basically, initially, as one of the speakers already told us, that initially there was mismatch between the demand and the supply. So once after the month of October, when the large number of vaccine was made available by the GOI, then afterwards we have identified some of the vulnerable groups for which we can work, and one of the group was the migrant population. So the NGOs, those who were working, were asked to work in the specific these areas, and they had worked quite good till today, till yesterday. They have vaccinated, means the specific record was maintained. That's why we have getting the figure of 9,000. So around 9,000 people has been covered. Also, now the activity is now speed up, and we will, in the future months, we will be covering more population of this migrant people. Then I will tell one of the story regarding the how the hesitancy was removed, not in the migrants, but also in the supporting persons, so that the people migrant can be covered. In the one of the district in Nagpur, where the TCIs were working, they identified the halt point where large number of the migrants were working there, and that was the petrol pump. That they want to arrange one session there, but the site where they can organize a session was not available. So after convincing the petrol pump owner or the manager, he agreed to give a site or the place. He arranged the place, and that helped in organizing a camp there. And at that time, initially, about 55 beneficiaries were vaccinated. And this continued, their efforts were continued, and due to this, more than 175 beneficiaries were covered at the same point after some sessions. So that helped us to boost the activity of the coverage in the migrant population, as well as that helped to give an example for the other NGOs also, that if the efforts are made, then they will get the success. Then all the NGOs who are working, means 4 NGOs are working, they are working for the migrants also, sugar cane cutter workers also, pre-clean workers also, mobile vans or the vaccination wheel activities also conducted by them. And coming to our overall performance, already I have mentioned that more than 17 crore vaccination doses has been given. Specific, if we see the 18 plus coverage is, our state's coverage is 93%, as it is a big population state. Now we are facing some type of hesitancy for the vaccine, but we will overcome that hesitancy also with the help of our partners. More than 35 lakhs precaution dose has been administered within 2 months' time. With this, I limit my words. Thank you.
Thank you very much for informing us about Maharashtra and telling us about your great efforts made in the shape of mobile vans to reach out to the migrant workers. Actually, Maharashtra was too much on the media glare, and you know that because Bollywood is there, and you know all kinds of things. So things are more visible. It's not that in other places problems were not there, but they were more visible there. But then there were some good stories also coming from Maharashtra. Some film actors, they helped, you know. And I think that is what civil society and government working together is a very, very good example that we have. And it is again very heartening to know that 93% is the first dose and 77%. And I believe that efforts must be made by the government, like Telangana told us that within 15 days. So maybe in another couple of weeks, we might have 100% coverage from Maharashtra as well. Thank you very much. Now, I would like to invite from Veena Kumar has come. Now we are left with Dr. Shailendra Paul, again Labor Department, Maharashtra. Yeah, please.
Good afternoon, friends. My colleague from Health Department, he has already given all the data. I would like to share the role played by the Labor Department in this vaccination and everything with the respect to the unorganized sector. We have population of nearly 11 crore and we have organized workers 38 lakhs, but we have unorganized sector workers 3.65 crores. During this lockdown, friends, you might be aware this is not my anyway, but during this pandemic and lockdown period, we have created help desk at all the railway stations and with the all labor department, and we have also organized camps, relief camps for the migrant workers, because we are having state borders, and you know that time the people were very rushing to move to their states, and those states were not ready to accept. So we have to take them back and we have to keep the camps for them, and there we have to arrange their health camps for them, and there we have to make the arrangements for the immediate arrangements, and it was very this thing in a big number. Not only the we can say interstate, but we have to face the problem of intrastate migration also. So that time the intrastate migration means the people from the one district to another district, they wanted to move to their native places, but they could not. Sugarcane cutter workers movement was very large that time, and the sugarcane workers were from the Beed district of Maharashtra, and they were working in the Pune and Kolhapur where the sugar factories were there. So we have to stop them. We have to ask all the sugar factories that they should make the arrangement of their stay, food and medication. So that problem we have faced. Then we have distributed free meals to the construction workers who were not able to migrate to their native states. So our BOC board, Building and Other Construction Worker Board, they have started the free meals, and we have to make the arrangements. We have set up of factories of preparing food, so that they and their family can stay there, and it was distributed free of cost to nearly 1 lakh construction workers in the state. Similarly, the board has also distributed 6,500 rupees cash to the building construction workers in 3 steps, so that they can survive with the other needs. In our state, we have started the Shiv Bhojan Thali. You must be aware that it was on the every railway stations and ST stands and bus stands for rupees 10 only. The most major part I would like to cover that, because these unorganized sector workers, they are staying in slum areas. They are not staying in very big areas. And our Dharavi pattern, you might be aware that in the Maharashtra, Mumbai, we have Dharavi pattern, which started Har Ghar Dastak. Every home was searched by the BMC, municipal corporation people, labor department people. We were going to every slum, every door, and that time we were having every person checked whether he is infected or not. And same we have repeated with the vaccination. So the whole Dharavi, it was a major part. It was cleared because of this Har Ghar Dastak. In Dharavi, sir, we have another type of unorganized sector. I would like to request the state government, central government, home-based workers are more. And these workers to be added in the list of unorganized workers list. So it will help very much that these home-based workers will get the benefits from the unorganized sector. This is what I would like to mention more with addition to my friend. And I will not take much of your time. I know it's very late. Thank you very much for giving me an opportunity to present myself. Thank you.
Thank you very much. No, you can be there. Just thank you. And I think you mentioned about Dharavi, and all of us are very much scared, because Dharavi could have been a, like a sitting bomb,
Yes,
because it would have really, things would have exploded. But then, thanks to, I think, government of Maharashtra and the efforts that were made.
Municipal corporation.
Yes, I think that was almost, I think, unheard story, like
Yes,
the world would like to hear, because what we did there, and I think something unprecedented was done there. Now, you have told about no one should be left behind.
Yes.
But I was very intrigued, you have mentioned build back better. Now, build back better is generally referred in terms of the paradigm shift in disaster management. Generally, you have Sendai framework where this term has come that if there is a disaster, we should build back better. What was there? But then in terms of vaccination, how this build back better is functioning in Maharashtra, I just would like to know.
Sir, same pattern is followed for the vaccination also. We have the setup and we have all the, what we can say, experience of the health checkup. So now we are doing the same thing for the vaccination. But what happened is the people wanted to move, and for that they wanted to go use the public transportation. And we have made that if you are vaccinated, then only you can go with the, you can use the public transportation. So people were after us that I want to get vaccinated because they want to move. Mobility was stopped. So even they could not go to the malls, or they wanted to go for job, or they wanted to sit in the, what you can say, as a vendor. So there also they required to be vaccinated. And you have to, on this, I will thank the government of India that you have that made the Arogya Setu, and the certificate has to be shown everywhere. So that made very effective, and that is why the people are coming that I want to get vaccinated. So that helped us a lot.
Good. I think that was a good strategy. So thank you very much. I think we are, is there anyone left out? I think all of us have spoken. And well, I think we have got a good sample of states from north, from south, from west, and from east, from Sikkim to Maharashtra, from Tamil Nadu to Punjab. And I think it's a good coverage that we have got, a good sample coverage. And we definitely learned a lot of lessons. Now I have my chair, Dr. S.P. Muniraju, Deputy Advisor, Niti Ayog. So I would request him now to make his concluding comments. Thank you.
So any questions from audience related to state's performance with regard to the labor or with regard to the vaccination drives? So.
State has taken initiative during this COVID crisis, and even online colleagues from different state officials.
If there is any state online who wants to present their initiatives with regard to labor, with regard to vaccination, so it's most welcome. Okay, so you can go for the question.
Hello. Good afternoon, everyone. My name is Lavrez and I'm representing Purpose here. A lot of states have done commendable work in terms of outreach they have done. Some of the states actually covered agriculture laborers in their presentation. My question is, like, due to pandemic, there is a lot of reverse migration also of migrants. We don't see migrants only accumulating in urban cities. So what role do you see of village level institutions, SHGs in terms of migrants who are moving back, and now they can't come back because they got settled there. And what role in rural sphere, the states are seeing in terms of vaccination, because a lot of presentations are focused on migrants in cities, in urban spheres. So I just want to have your thoughts on that. Thanks.
Well, it's a very good question, in fact, and also I anticipate that question. Well, how? Because states has the responsibility to meet to the requirement of the people, and migrants issues till recent times it is like a hidden subject, and no one was bothered about migration, migrant workers issues and all. Once when pandemic happened, lockdowns announced, and all of a sudden migrant workers started to going back to their native places because they were not able to find the jobs where they moved. So the governments also became very sensitive and started providing the employment opportunities under MG Narega wherever it is possible, and started providing skill trainings. And also, I really appreciate that even today the civil society contribution is huge. And if possible, I request all the audience to give a great applause to the civil society's contributions towards the needs of the migrant workers. They have hugely contributed by providing food, by providing sanitation, sanitizers, masks, and all COVID related care and awareness generations. Besides that, many of the civil society organizations started providing shelters and also started providing them jobs in their, especially the Pradhan, one organization which started creating additional employment opportunities through their CSR contributions. We do appreciate CSR. Similarly, many of the corporates on a clarion call from the Honorable Prime Minister, they started providing help to the migrant workers through civil society organizations. And UN agencies really, they engaged many of the civil society organizations, including WHO, started providing health screening and getting the oxygen cylinders and oxygen concentrators. Many way, everyone has contributed. And of course, many of the civil society organizations, they closely work with district and state administrations, where from Niti Aayog, we have given a clear-cut directions to the civil society organizations and also district administrations to closely work and attend to the needs of the migrant workers. One is with regard to creating job opportunities at the locally. Many of the departments, especially under MG Narega, because that is the rural development flagship program where employment opportunities were provided. Even additional funds were provided by the government of India to the state governments to create job opportunities locally. And many other occasions like food distribution. Without any ration card, we started directed FCI and also the state PDS shops to distribute food grains, so that no one suffer from hunger and malnutrition and other issues. So, and health checkups. Of course, we know that we started initially, there are some vaccination problems happened, but in the later stage, once go free vaccination drives have taken place and many occasions. And even today, today we have achieved about more than 196 crore vaccination doses of vaccinations have been provided across the country. This is all because of the proactive initiatives from the states. I really appreciate, and I request all the audience to give applause to the states, because if today India has achieved so many doses of vaccination, because it's the effort of the states. Unless the states have taken the proactive role, we could not achieve today's vaccination. And if you see the globally, India is the best performing in terms of vaccination is concerned. Well, we have certain apprehensions or vaccination hesitations among some members that needs to be addressed. Maybe later in the later stage, we can achieve that 100% vaccination in the country. So hope I have addressed your question.
Sir's comment. When an ANM goes to When an ANM goes to a village and in our Har Ghar Dastak campaign, the ANM never asked, are you planning to settle back here or are you planning to go back? So this question was never asked. And that is the reason that anybody who has got vaccinated in Punjab and gone back to UP, he has got himself. And if a person from Punjab has, UP has come down to Punjab, we were able to. There's technology that we used, CoWIN helped us in that because there was a universal and uniform platform where every citizen will be vaccinated and have a uniform vaccination iCard. And that really helped us. There was an equitable distribution of vaccine that was made available to all the vulnerable sections along with other sections of the society, I guess. I would also like to bring about, emphasis that there was a lot of out migration, especially when I talk about Punjab, because a lot of out migration happened in the form of students, in participants for the Tokyo Olympics. And I think with our vaccination that we had, that was actually worldwide recognized and accepted, we were able to vaccinate them fully and send them comfortably with a digitized form of vaccination ID as well. So if overall nationally we're standing at 98, in my state at 98 and other states more than 100, that means that if my people have gone to their states, they are also vaccinated. Yeah, thank you.
I had a point here, sir. So to just add your point, doctor, I don't know his name. I just want to. Can I get the exact question what you want? The immigrants, there are rural immigrants back to home. You want to say that whether they're 100% vaccinated or not. We are only talking about urban migrants or urban industry sector. If I take your point right, the answer is rightly what she said also. COVID platform, it's a pan-India platform. Gives us with a single Aadhaar, we can find where is vaccinated. There are two limitations in COVID also, because if I take my Tamil Nadu state, I have a district population. We have a revenue districts. Apart from that, we have the health unit districts. And below that, we have called the block populations. We can't find the block saturation in the COVID portal. Thing is, if I take if my block population, say about 1 lakh eligible beneficiaries, if I'm getting all the 1 lakh beneficiaries vaccinated, I can say my block is 100% saturated. But what happens is, in a block PHC also, someone from other areas can also get vaccinated. So it doesn't come under a denominator pattern. The right point is what she said is also, by Har Ghar Dastak campaign, door-to-door campaign, my ANM goes to each individual house, say whether you're vaccinated or not. Yes, if you're vaccinated, she takes a mobile phone in the COVID portal with the mobile number, she identifies the number and says you're vaccinated or not vaccinated. They may tell the other way also, I'm vaccinated, but the COVID clearly says that with this mobile number, you're not vaccinated. So he may say about, I was using another mobile number. She will be trying again the other mobile number. When it's not coming into the confirming the vaccination status, we are giving the vaccine to them. So this is how we are saturating the block-wise population to say that even the migrants back into the rural areas also getting vaccinated. And respectable Honorable Minister for Medical and Family Welfare has clearly announced that each panchayat or each municipality having 100% vaccination will be rewarded by the Honorable Chief Minister. So this is the way we are targeting those people also. Thank you.
Hi, good afternoon, everyone. I am Rahul Banerjee and I represent Rice in a House over here. We are a policy research think tank. So it was an absolute pleasure listening to all the states on the achievements in vaccination. There's one simple point that I would like to ask is, what are the state's policy regarding vaccination of refugees? Especially in terms of Delhi, Delhi has a vast number of refugees, about 20,000 Afghans, if I may point out. And up until November 2021, there wasn't a single individual that was vaccinated. And it was after that me along with some representatives from the Afghan embassy over here, we had to run from private players door to door in order to convince them and take care of the vaccination hour after UNHCR was unable to bear the cost for the vaccination. So if there is any policy regarding vaccination of refugees. Thank you.
Hello. My name is Binoy Peter. I work for an NGO called Center for Migration and Inclusive Development. Not just the case of refugees. I think people from Nepal, there is a substantial number of migrants from Nepal in India. And I think just the passport is recognized for them for as an identity proof for vaccination. And unfortunately, there are a lot of people who do not have passports, and their national identity card is not recognized by Government of India as a document, valid document for vaccinations. So I was wondering whether this could also be.
I think I got a question. Thank you. The point is, initially, this was a problem. Without any ID card, we could not vaccinate. We could not give anyone COVID vaccine. So because that was a rider. But after the vaccination was allowed for the people without identity card, I think we have almost covered all. People have come from Pakistan, stayed near Majnu Ka Tila. A lot of people are there. People have come from Afghanistan after that crisis. People have come from various countries, like you have mentioned, Nepal also, and people are coming from Bangladesh. But everyone, whosoever, whether he is a beggar, whether he is a refugee, he is not having, he or she is not having I-card. Now it is possible via COVID to vaccinate for everyone without ID card also. And emphasis is on to vaccinate everyone who is in the boundary of the state, whether I-card is there or I-card is not there.
So the Afghan passport or the national identity card is not yet accepted as a valid ID. And so, yeah, as I mentioned, there are Afghans who are not yet vaccinated. So yeah,
good question. Of course, this was not brought to the notice of maybe the Delhi government.
If the details can be shared with me personally, I'll ensure that if anyone is still remaining, they will get vaccinated.
Sure, thank you.
Thank you. So we can conclude. Thank you so much for all your participation, active questions, and state's response. So once again, it's a great work done by the state governments. It's maybe labor department or health department and other departments also, police, everybody worked together. And this has brought really great name to India at the global level, because India is today having its status at the global level in terms of vaccination is concerned because of the states. So congratulations all the states participating here. Thank you so much for, and I also congratulate IOM for taking this initiative, and Sanjay Awasthi and other team of IOM is doing really tremendous job. And now I request to honor the delegates here and the chairs and the state representatives.
I would like to congratulate Niti Aayog also.
Just want to utilize the platform for you to make an appeal to you all, because everyone has congratulated the state health departments and every department, and of course union health governments. Thing is, for last 2 years we work on this COVID. Still now there are pending doses to be given. Only thing is the people should have the behavior change communication. No more IEC will work here. If there is COVID and there is a problem of COVID, there is a precaution that is eligible for me. Let me come and get vaccinated. How can a healthcare worker going every door is possible? But we are doing it. We are doing it because we are committed and we are doing it. But ultimately, this is a time for them to have a behavior change communication. Let them come and get vaccinated. Because our health staff also got fatigued. 2 years they are working. And of course, we are compromising the regular health team work also. So that's an appeal from us. Thanks a lot.
Thank you very much to Professor Joshi and Dr. Muniraju, and thank you also to all the panelists for sharing your experiences and insights. We'll now break for a 45-minute lunch break. So please enjoy your lunch, which is served right outside the hall, and we'll be back in the hall at 2:20. Thank you. 2:10, pardon me. 2:15, pardon me. 2:15, we'll be back in the hall at 2:15. Thank you.
Hello, just checking if the audio is working.
It's working, it's working.
Great. So I'll,
I was
okay,
on mute.
video,
Yelling at the top of my lungs.
video, do you want video as well? Let's see.
Yeah, that works.
Can you see me?
I can't see you.
Oh, right. I can't see me, so I'm very confused.
Yeah, no. I can see you and I can hear you quite properly, actually.
Okay, perfect. Great. So I am logging back off and I will log back on, I think in another, what, how many minutes do I have to log
10
back on? I think 15.
2:15.
Okay, so in 10 minutes. Ah, there I am. I'll see you in 10 minutes, okay?
Okay.
Bye.
Bye.
So welcome back, everyone. And I hope you enjoyed your lunch. In the last session, just before lunch, we heard from state government representatives, and many of them talked about the role that civil society has played. In the next session, we'll hear from civil society organizations that have complemented the wonderful work done by the government. To kick that off, I'd like to talk a little bit about a global program called Verified, which is a collaboration between the United Nations and the organization I work for, which is called Purpose. Purpose is a social impact agency which builds movements and runs campaigns to shift hearts and minds on pressing issues. We do a lot of work around climate change, a lot of work around public health as well, specifically including COVID. Verified is a global communications infrastructure to address misinformation on COVID-19 and also to promote accurate science-based information instead. We've reached roughly 1 billion people in the last 2 years, and we've helped drive vaccine uptake, COVID-appropriate behavior, and dispelled misinformation. A study by the Massachusetts Institute for Technology, for example, showed that our campaign was able to slow the spread of misinformation online. In India specifically, we've reached 250 million people in 11 languages, and we've had measurable impact. For example, we were able to show a lift in vaccine uptake of 19 percentage points in those touched by our campaign versus a comparison group. And the way we've achieved these results is through 3 pillars. First, we have an insights engine. So that's composed of primary and secondary research, online and offline, that tells us what key communities, especially vulnerable or hard to reach communities, what their pressing issues are today, because obviously COVID was very dynamic. 2, we have understood that faced with ambiguity, what people really need is trusted messengers, people that they personally trust. And therefore, we've put information in the hands of those trusted by hard to reach populations and then help them amplify their voices. And 3, we've built a communications infrastructure in India that includes more than 500 CSOs, social media platforms, businesses, celebrities, faith leaders, doctors, scientists, foundations, government representatives, etc., to get accurate information out there in the voices of trusted messengers. And going forward, we've realized that the same infrastructure and these same trusted messengers can be used for really any issue where there is a need for verified information, and for that verified information to be disseminated and to be believed. And we're therefore continuing to work with the UN to see how this infrastructure built for COVID can be used for other public health or other issues. Purpose is very proud of this collaboration, and I'd like to conclude with a short video of the highlights of this work from India and around the world. So thank you for listening, and now let's watch the video.
COVID-19 can be characterized as a pandemic.
5G causes coronavirus?
As the COVID-19 pandemic spreads, another virus is infecting our lives, misinformation. That is why we are launching Verified.
Verified was created by the United Nations and Purpose to tackle misinformation.
It's really, really important to get factual information out there.
This is one of the largest collaborative exercises that science has ever seen.
Do not self-medicate, get tested and treated.
Verified has activated over 70,000 information volunteers to share fact-based, life-saving advice. The campaign inspired hope and solidarity for a truly global recovery. Verified has reached more than 1 billion people in 130 countries in over 50 languages.
से अधिक महिलाओं ने और पुरुषों ने वैक्सीन लगवा ली है।
good communication saves lives.
Thank you. Thank you for watching that film. And now we have a panel discussion on the factors behind, on the factors behind vaccine reluctance and acceptance, and recommendations to improve COVID-19 vaccine confidence and demand amongst migrant workers. I'd like to invite the chair of this session, Dr. Sumantra Pal, Economic Advisor and Joint Secretary, MOWCD, to please address the audience.
So there are two kinds of people in this world. One are humans, another econs. And econs, I classify myself as an econ. Like we follow rational decision, we take decisions based on reasons. And I'm also human in a sense. Like I take sometimes like not rational. We donate to people. Economists, they will say, why should people donate at all? I mean, they should always maximize their self-interest. And humans donate. So that's the difference basically, because the humans and econs, and all through these two slides I have only, and very intense kind of content. So two Nobel laureates from whom we draw the inspirations and their knowledge, and we just mark it here. Does it? Yeah. So three cognitive bias that since morning we have been hearing, that why vaccine hesitancy, why vaccine avoidance, this sort of syndrome comes up. It's not only vaccination, it can come up in any walks of your life. So three cognitive biases I pick up, which is particularly relevant for vaccine hesitancy and vaccine avoidance. Kind of the first one is confirmation bias. So you have some myth in your mind, you believe something, and the prior belief that you have in your mind that vaccine cannot come so soon. I mean, if it can arrive, usually it comes after 10 years of FDA verification and all. Now you're getting in less than 1 year time. So that is incredible. And people have that belief that pharma companies are doing it very, very fast because they can reap the benefits. They work least in public interest, and therefore we should not believe in this vaccine. So that is a prior myth that is ingrained in people's mind. People are used to this long span of time it takes for vaccine. Now, if you have this prior belief in your mind, what you will do, humans, they will behave in a way that you will be accepting evidence whichever is supporting your prior belief. Whichever information that is given to you, whatever IEC form you deliver to people will not believe you, because people have their prior belief in their mind. 51% Americans, they believe that the pharma companies came up with a very quick kind of vaccine which is not going to be effective and which will have more side effect. And that comes a negativity bias. So you believe that negativity, for anything comes negative in front of you, you are more susceptible to accept it as given. And whenever you find, okay, people have taken vaccines and they have had side effects kind of thing, then they will think that this vaccine is not effective. It might even get you infected to COVID. That kind of syndrome will happen. So how do you address it? I'll come to the next slide. Just I'll say the next bias that you have. You think, I will not face any kind of negative events. I'm very strong, so I'll not have COVID at all. So why to take vaccine? This is third kind of bias. Now, how to address this in your IEC? Now, first, if you go and spread out your IEC that you should take vaccine and it is good for your health and you will be protected against COVID, if you asked for, if you deliver this kind of information, it will backfire. Why it will happen so? Because you are giving a corrective set of information to reduce the belief they had in their mind prior to you gave the IEC initiative to them. But it will be further reducing that if you are susceptible to believe that vaccination is causing side effect, or you are very much concerned about your side effects, then it will reduce your intent to vaccination. So this will happen. Third thing, it will happen like more and more ICU spread on these lines. So people will recall their original myths they had there in their mind. So that will again reinforce that belief that, okay, don't take vaccination and it is going to backfire. Second thing you can do is that the 4 options I gave. So first is you do not do. The first bullet was that you do not do that. What do you do is that there is something called reactogenification. What happens, you take the vaccine and you teach people, suppose you mold your IC in a way, you educate people. Once you vaccinate somebody, you educate that he will have this kind of side effect for 2-3 days, be aware of it. And you also tell them that if you take this vaccine and if you have these side effects, you will be doubly sure that this vaccine is working on you, and you are generating like antigen kind of thing, or kind of protection against the disease. So nothing to worry. You be happy with your side effects, and side effects is a double assurance that vaccination is working on you. So the frame is changed, and people will be more acceptable to your IC efforts. Then you should stress on your pro-social behavior. Like suppose you give an example that if you have COVID, no problem. But if your elderly people or your children, they have COVID, then what will happen? So therefore you should take vaccination. So you improve pro-social behavior amongst their own family frames. So then people will also be concerned, okay, my family will get, even in the data, you will see that women are more accepting kind of vaccine kind of thing. And then the last option is that opt-out strategy that you have more or less adopted, that you go to Har Ghar Dastak and you go to them, and then everybody on saturation basis you need to vaccinate. So that is the thing. And for further readings is Daniel Kahneman, he got Nobel Prize in 2002, and Richard Thaler, he got 2017 Nobel Prize for this work. And very famous book, Daniel Kahneman, you can read that, Thinking Fast and Slow. Nudge is another famous bestseller from Richard Thaler. So if you read these books, you'll get a lot of ideas, how to nudge people, how to without spending any money, you can affect people's behavior. And especially for SBCC that you are working on primarily. I stop here and then get to the moderator to take on.
Thank you for that, Dr. Pal. I'd like to invite the next panelists and the chair and moderator on stage. As the chair, we continue to have Dr. Sumantra Pal. As the moderator, we have Dr. Sanjay Kumar, Population Dynamics and Research Specialist from UNFPA. And we have as panelists, Ms. Roshni Nukkehali from Yuva Mumbai. She'll be joining virtually. We have Ms. Anjali Borhade from Disha Foundation. We have Ms. Mandira Kalan from Purpose, who will also join virtually. We have Dr. Aparna Joshi from TIS, also virtually. We have Dr. Binoy Peter from CMID. We have Dr. Shantanu Pramanik from NCAER. And finally, we have Mr. Pratik Priyadarshi from Jan Sahas. One request to our panelists, if you could please restrict your answers to not more than 3 minutes per question, that would be great. Thank you.
Hello. Okay, well, good afternoon. And after lunch, it's going to be a bit heavy, but I think we have got a galaxy of panelists here physically present, as well as we have got at least 3 panelists online already. I saw them on the screen. So without much taking time, I think Dr. Paul has already set the tone, and with his permission, we'll start. So what we will do, what is the format of this panel discussion today is that we have a certain set of questions to each panel.
I think they've gotten disconnected.
Hi, Dhruv. I think we have got it. Yeah.
So okay. So why shouldn't we? We can go back a little bit later, and then in the interest of the time, let me first ask my friend Binoy Peter. And also, I'm so thankful to Bina as well as Shantanu, because they were the part of the technical advisory committee of this study, which I forgot to mention in the morning. So thank you very much. We learned from their experiences. So Bina, for you, because you are dealing in Kerala, you are dealing with interstate migrants, and you know their situation at the place of destination, and how do we try to improve? So the question to you, how can we ensure that interstate migrants workers are covered by the vaccination programs? And how do we address various challenges which they face, and they should not be excluded for the public healthcare system at the place where they are going, because this is an unknown place for them? So your thoughts, please.
Thank you. And instead of just talking, I'll also show some images that so that people are able to relate to it. I think what is most important is most people who migrate, whom we say migrants, prefer not to migrate if they get about 10,000 rupees on an average at their native places, which is going to be a distant dream for rural India for a long time. And these are people who are mostly from the socially and economically disadvantaged populations. And the moment you cross a state border, you have additional vulnerabilities in terms of language and other stuff. So we were discussing about vaccine hesitancy, vaccine reluctance. At the same time, there is also kind of vaccine desperation also where people are interested. So for interstate migrant workers, I would simply put it, there are three factors that work. It is demand creation, provision of quality services, and an enabling environment. So unless and until you do a solid demand creation, because these people, as I mentioned, are from marginalized communities already, so they would require a lot of investment in interventions, focused interventions for understanding in these situations. For example, unless and until we know from which state these people are or which sector people work in, we won't be able to do a solid demand creation. So if people are from West Bengal and your outreach strategy is in Tamil, it doesn't work at all. So there is a lot of interventions in terms of demand creation that is required. And in terms of provision of quality services, and we all know that the public health system, particularly the OPD, work in conflict with the work timings of the migrant workers. So it is important to reach out to people with at a time convenient to them, at a location like what you've seen here. And you can just keep showing the other images. So reaching out to people at a location and time convenient to them with a group of people who can communicate to them can really help in terms of providing quality services. So there are people who provide services at their native languages in terms of demand creation and at a place which is convenient. This is a bricklane. Bricklanes are generally in the peripheries of the cities where it is very difficult to reach out. So if you go to the bricklanes by the evening when the sun is about to set, the workers will be relatively free. And there are also specific categories of workers like not the people who work in the factories. There are people who are known as footloose laborers who come to a labor naka and then look for opportunities. So we will, if you need to reach out to them, we need to have evening vaccinations, mobile vaccination units, etc. And the third most important thing is an enabling environment, which is generally lacking. One, it is, you need information, research evidence, and then we will require political will, and there is a need for partnerships. We know that the human resources for health, public health particularly, is not substantial. So it requires synergies. There may be civil society organizations like us who are interested in doing flexible intervals, like we would be happy to vaccinate on Sundays or late evenings. We have done over 70,000 COVID vaccinations among migrant workers. So, but we do not have funds. But if there is an organization, a private sector entity, which is having funds or willing to share, and then government is willing to share vaccine, provide vaccine on a Sunday or in the evenings. So these synergies in terms of evidence, political will, and then partnerships. Partnerships is that what works very well in terms of doing so. Not a single part. CSOs won't be able to do it on silos. So it is partnerships that work. And these three things, if we work, demand creation, quality services, and an enabling policy environment, things will work out. And this is simple social marketing strategy.
Yeah,
thank you.
Thank you. Thanks a lot for putting these three things which can help, to improve the situation. But just as a follow-up question, what do you think what the government and at least the employer should be doing some proactive work so that the three factors which you're talking about should be in place? So what would be those?
I think it is the best interest of the employer to make sure that your workers are most productive. So it is one of the best investment in terms of making sure that you take every preventive step in terms of primary prevention or secondary prevention to make sure that people are able to reduce out-of-pocket expenditure. So that is what I said. We run mobile clinics working with National Health Mission and also with the employers. So we are allowed to take our clinics to some of the most vulnerable, areas like bricklines or fish processing units, or so it is a kind of mutual trust that we are all working together for the welfare of the workers, and ultimately this is the best interest of the employer, which is going to work. And I think it's most importantly, currently it is CSOs and government investing, but probably the employers and the employers and business organizations need to come forward and substantially invest in the welfare of the migrant workers.
Thank you. I think this is a very important point that yes, government is doing a lot, but I think for the interest of the employers, they should also come forward and join hands to do work together. So thank you, Peter, for your valuable insights. Can we have Rosni ji on now? Has he joined?
Yeah, I'm here.
Okay, thank you, Rosni ji. Thank you that you are a part of the panel here. We really wanted that you should be in person, but anyway, in spite of that, we are connected with you. So just to get some of your perspective, what according to you are the major barriers that particularly women migrants or the women in the migrating households they face in terms of accessibility and all? And what are your recommendations and suggestions, and how do we overcome that?
Sure.
Over to you.
Thank you. Thanks a lot. I hope I'm audible. Thanks for having us here. I'm from Yuva. We are an organization based here in Mumbai and working in different cities. And I think the COVID experience was a huge learning for us and working a lot with particularly internal migrants. So I think that will be the experience which I will share with everyone today. I think overall, before even jumping into the barriers for women workers, I think it's important to understand the layered causes, which we've already spoken about also, I think, through the study itself. Internal migration itself it makes you invisible. Lack of connection to the city, lots of separation also from families. I think that's a reality of migrants. And then COVID itself was this whole fear factor, misinformation, and then on top of that was a lockdown, which again, when it was initially brought out, came about in a quite a dictatorial way. And finally, May, when the migrants were allowed to go back home, extreme misinformation, lots of politics playing. So it was in this backdrop of fear and lack of communication and actual health issues added on to my internal migrants, own identity, lack of identity in the city, that the vaccination was launched. So I think we need to understand that context and how it is layered. And hence, the lack, why will the migrant trust this system where this has been the way in which the last 1.5 years is actually 9 months particularly has, so hesitancy was also natural, I would think. And then, of course, we know the process of the delivery, whether, initially the age range, it was initially free, then the huge costs, and the digital mediation, which were also, quite an important factor. But I think for women, definitely there is the overall patriarchy in terms of the family, who gets access, who doesn't. But the other point I think was during COVID, a lot of women lost formal work. They became restricted to the house. And because of that, the need or the imagination that vaccination is needed started to become less as well. On top of that, misinformation related to particularly gynecological issues was a huge barrier as well for women. And the digital mediation, we all know that it's really not the women in the household who have phones, particularly not the older women. And for them to step out of the home to get the vaccine, it's not just losing, a daily wage, but it's also who's going to look after the children, the care work. What about all the other labor that goes on? So I think that was another additional barrier that women definitely faced. And in terms of, how do we move beyond this? Of course, not just for the remaining vaccination, but also in general, taking off also what from Binoy is saying, really strengthen public systems at the local level. I think that was what really, where we saw strong local systems, decentralized systems, that was where women's uptake was also very high. And ensure that there is trained human resources there. So clearly this is a space for the government to act. But at the same time, we also need to build that community of trust for women. Are we reaching out to existing SHGs? Are we reaching out to Mahila Mandals? Are we reaching out to Anganwadi Sevika? So really looking at the existing groups of women, of young people who come together, how do we ensure that we can build trust through that? And I think that is, huge role for civil society. We've used that a lot. And finally, I think when we work with women, we have to be contextual and specific, right? We do need to have generic principles of when do we do the vaccination, how is it done? What is the IEC that is delivered? What are the, information that's given? But on the ground, that work has to be very flexible and relevant. When Binoy spoke about when does a vaccination happen? How does it happen? Are we making sure we provide private spaces if that is the need? And what else might emerge if people are coming and taking that vaccine? Maybe there are other fears that are coming to play, whether it's related to health, whether it's related to psychosocial issues. So I think when working with women, that becomes very important. And that's where this whole point of collaborating between both the state, and when I say state, I mean very, very strongly, I push for the decentralized spaces and then civil society. I think that would be very, very important.
Okay, thank you very much. I think giving you had given a lot of good perspective. Just as a follow-up, do you think that to promote vaccination among migrant communities, do you see any role of the young people even from the same community? And if so, what will you suggest?
No, most definitely. I think, young people have played a huge role throughout the pandemic, and even an organization like Yuva, we're also called Yuva, we were really able to leverage on that. We promoted, this is just an example which then went quite wide in the state of Maharashtra. The vaccine help desk was a concept wherein basically young people, because the sense was that young people weren't getting COVID in the initial phases, were actually able to go set up desks in locations, some were mobile, some were not, and then talk to people, spread information, but also actually do the COVID registration, then make the follow-up, if this is the date of your first vaccine, when is the next one? And these are young people from within a community. And we saw them really come forward to do this in a big way. So several help desks, we were able to reach out to, even as a small organization, 6-7 lakhs people we were able to reach out. And young people started innovating quite a lot. When they realized that people were hesitant, they would find people in the community who had taken the vaccine. And make them sit at the desk to really talk about, see, it's safe, you can do it, so on and so forth. Sometimes they started networking with private doctors who were also giving pro bono time to sit at the desk to break some of these myths, because they, of course, young people could not do that medical role. And they were clear that that is not their role. A lot of the time they started making connections and relationships with the vaccination centers. So saying that, Friday afternoon, we will bring all the people from this basti and take them there. And these are all migrant bastis. I'm giving you examples from a city like Mumbai. So I think young people with the general, definitely the energy, but also their ability to innovate on the ground, to convince people to go the last mile and do those follow-ups, because not just one vaccine. We also saw a lot of people didn't take the second vaccine. They were women, they were older people in the homes who were refusing to come out, making sure that, the local ward office arranged ambulance services to take the older people to the centers. A lot of these innovations they really did. And I think it really, really played a huge role. And again, not just in the vaccine space, young people are able to really use their both their energy, but also ability to critically question the way things are happening to propose better solutions. So we definitely saw a lot of that happening.
Okay, thank you. I think this is the one when we talked about, community mobilization for this vaccination program or any other thing. So probably there is a need to engage with the community, maybe young persons, or maybe, those who are favorable, like positive deviants and all. So that will go a long way in future to get, more community mobilizations. So thank you for your inputs. Now we move to our other panel member. She's also online. Mandiraji from Purpose. And we just saw a very nice video where verified and how you all handled the misinformation about COVID-19 vaccination. So we just would like to understand what were the strategies, tools which you implemented, adopted for reaching out to so many people and then verifying, providing the verified messages. Over to you.
Thank you and good afternoon, everyone. I hope I'm audible. So I think Purpose used a number of strategies to counter misinformation. And one of the key things that we started by doing was to identify information gaps among target audience, but not to identify them ourselves, but really to use what we call verified parties, trusted messengers from the communities to collect frequently asked questions directly from our target audiences. What did this allow us to do? It meant that we were building communication and we were fact checking based on data and evidence coming directly from the community. And something that's come up in both the previous panelists have talked about the importance of local needs and requirements, local context. So by going to the audience to understand where the information gaps were, it allows you to tailor your communication to those local issues and requirements, to build hyper-local campaigns to ensure that messaging for women is really speaking to women and it is not generalized messaging. Another thing that we did was we worked with collaborators. And by collaborators, we worked with fact-checking networks. There are fact-checking networks such as the Misinformation Combat Alliance that share trends of misinformation, that tell you what are the large patterns and trends, but really using these collaborators again to understand how trends may be specific to certain groups, certain audiences, certain vulnerabilities. Once you have these myths, these information gaps, and you collect these myths and information gaps, you start to see patterns, you start to see commonalities, and strategies can then be built around this misinformation, misconception. The strategies can target things like hearsay, things like partial information. And all of this leads to information that becomes relatable, but also relevant for our specific audiences. So that's just a broad idea of what we did in terms of fact-checking and dealing with misinformation.
Okay, thank you very much. I've just trying to relate it when Dr. Paul has presented on misinformation and the beliefs, and it says if we over handle those things, so probably it will reinforce. So it's better to not, emphasize and all. So taking lead from there, what do you think that, sometimes tackling this misinformation can also backfire? So how do we actually effectively navigate and those situations and build resilience against misinformation?
So I think this is quite the interesting part about misinformation, is that while many of us understand this concept of fake news, misinformation is far more complicated. It's complex. It's a lot more nuanced. And in India, for instance, even where we may have specific sources for trust, especially related to COVID, even where we did have specific sources for science-based information, maybe a one-stop source such as government sources, there was a lot of discreditation of those sources by misinformation, by fake news. As Dr. Pal said at the beginning, there was mistrust around why this vaccine, why not the other vaccine, why so quickly. So what do we need to be doing? We need to support organizations and networks. So you're building large networks which have scientific and fact-based information. We need to monitor trends. We need to monitor narratives, the kinds of messengers that work. We need to monitor what is the impact of existing work, what are new developments that can impact, real-time events that could be impacting the issue. For instance, something that I'm sure many of us have been talking about over the last couple of months is how do the current heat wave conditions impact either COVID vulnerabilities or vaccine uptake? Also knowledge sharing, but not just knowledge sharing for the sake of knowledge sharing, but really about knowledge sharing built on impact measurement and learning and sharing across networks, partners, government, donors, really building a knowledge network of what misinformation means, the kind of misinformation out there. We need to strengthen media infrastructure to reach mass audiences and to specifically target vulnerable populations. At the same time, we also know that many communities, especially vulnerable communities, do not have access to mainstream media, to digital channels. So what do we do there? We collaborate with local and grassroots groups, like the partners on the panel with us, so that we can engage communities directly where required. And I think one of the critical things that we have found with our work is really about growing, and my colleague Govind also mentioned it when he spoke earlier about Verified, was really about growing a coalition of trusted messengers. And these trusted messengers are relevant to the community. They are people that the community believes and listens to, and really engaging them to persuade their audiences. And they're relevant for certain audiences. So really using trusted messengers in a targeted manner for the audience that will listen to them. And I think a combination of all of this happening really helps then create almost an ecosystem of trust, which can then help tackle misinformation, that can then handle the risks and the potential backfire amongst audiences, because it's coming to them from trusted sources, because there's an ecosystem of science, evidence, narratives that speaks to them, that's relatable, that's relevant, that's also verified. So I think these are some of the critical things that we can do all together to help build resilience against vaccine misinformation.
Okay, thank you very much for all the combination of efforts which you are referring to. Thank you, and I think all the best for your work, and probably we have learned a lot. Now we move to our another panelist, again through virtual mode, to Dr. Aparna Joshi from Tata Institute of Social Sciences, Mumbai. Hi Aparna, nice to connect with you. And we are working together on the mental health aspects of young people and also, but here we are going to ask you, get your mind regarding the mental health and well-being of the migrant populations, particularly in the wake of when they are exposed to misinformation, fake news. So what are its impact on their mental health? And then later you can also suggest, how do we try to handle those things? Thank you. Over to you.
Yeah. Thank you so much. So I think I would like to first of all talk about this infodemic and its overall effects on the psychosocial sort of well-being of the communities itself. So during COVID, we saw two things. Given the digital divide or overall, reach of information, there were some parts of India who did not have adequate information, and for some parts of India as well as the world, there was overabundance of information. And definitely, I think that information was used as a coping strategy also, because especially during initial phases of COVID, the impact that was created was typically uncertainty, a lot of fear. And one of the ways in which people tried to cope was definitely through finding more information. At the same time, more information would have meant all kinds of information, true information as well as information which is not scientific, which is not trustworthy. And we saw a very vicious cycle of trying to cope by finding information, but the very false information creating further anxiety. And instead of creating certainty and helping people reduce the amount of stress, it kind of created this entire, sort of infodemic of, alongside COVID also. And WHO also has recognized some of the ill effects of this. Again, when it comes to migrant communities, I also want to say, apart from teaching at Tata Institute of Social Sciences, we also run a national level helpline, which provided some special psychosocial counseling services during COVID. And we received more than around 200 calls within the first month itself from migrants. And this information, apart from hampering people's psychosocial well-being, definitely did one more thing, which is to create an impact on social fabric. A lot of stigma, lot of discrimination, lot of hatred, violence. And we saw that migrants were tremendously affected and were recipients of this stigma, of this discrimination and violence by the general public. We heard, the desperation to go back. We heard their identities, which did not feel fitted into the cities, but they were not welcomed home also when they went home. So I think it was a very, very difficult time for migrants. And I also wanted to take this opportunity to talk about one of the missing link in migrant work, which is mental health and psychosocial, because we are talking about COVID, we are talking about public health, but mental health is always a missing strand in migrant work. And I just wanted to take an opportunity to talk about, okay, migrants were affected, mental health was affected. At the same time, we realized that there was a huge mistrust in terms of accessing mental health services, right? Just as there was perhaps hesitancy in accepting vaccine, there was also a lot of mistrust about government services and also about mental health services. Overall, all of us know that mental health as a topic is shrouded with a lot of stigma. 170 million people in this country are in need of mental health services, but we have very less number of professionals who are available, and the available services themselves need to be looked at 4 or 5 dimensions: affordability, accessibility, definitely quality, and its relevance. And I wish to say that unfortunately migrants did not show great faith in government services, government information, or government mental health services. Also survival was primarily an issue during the initial stages, but mental health impact also was seen a lot, definitely. And I have a few things to say also about what can be done to address that, because it's often a neglected issue. Yeah.
Okay, thank you. I think you talked about that. Yes, this component was a bit missing about counseling and other thing, and good that you had a helpline. So what do you think that let's think for future, if some eventuality happens and like new vaccines, and there are many things are being on different fronts, so many things were actually done, so many activities, particularly on the psychosocial and mental health aspects of any population for any pandemic or any kind of a situation, or what could be the good way to go about, and how do we prepare, how do we start? So just like to get some idea from you.
Sure. So I think why migrants don't find existing mental health services relevant, I think that's also very important to look at. And what are the barriers that are experienced? I think first of all, mental health is always understood in a very biomedical approach. Whereas if you look at the journey of a migrant, even before they start migrating or post-migration, or even the journey of assimilating into a new space and culture, it is full of stressors, which are perhaps economic, social, educational, identity related. So I think mental health services need to move away from their biomedical understanding and need to understand this journey and the several stressors that migrants are likely to face at different points in this journey. I also want to say that migrants are not one monolithic, homogeneous group. There are women migrants, there are children, there are definitely perhaps LGBTQ individuals, there are individuals with different languages, and we need to create mental health and psychosocial services which are also generic but relevant for these special vulnerable groups within migrants also. And apart from giving medicines or diagnosing people, see, diagnosis in a country which already has stigma around mental health and stigma and discrimination against migrants is going to cause further fear, anxiety. So we require understanding mental health through a different lens, maybe need to dialogue with migrants as to what can be done in order to provide mental health care. And there could be community-based approach, there could be self-help based approach. Perhaps there is, and my most important submission here is mental health works in silos and migrant works in silos. I feel that mental health has to be an essential and integrated component of all migration efforts. And it can't be just through the government mental health service delivery. Given the huge need for mental health work amongst migrants, specialists can never suffice. We require task shifting, which means whoever are the community stakeholders who are acceptable support systems to migrants also need to be trained to provide basic support, to provide basic referral, language, stigma, undocumented migrants, their fears, all of this needs to be understood, and more psychosocial conceptualization is required, whereby you offer a cafeteria of choices of mental health responses and not just medicine and diagnosis. Maybe that will go a long way in sort of, integrating this component. But all migration related response has to integrate mental health and psychosocial work is my sincere request.
No, I mean, I totally agree with you, and thank you for underlying this particular thing. So it is not only in pandemic situation, but I think the way we are seeing, how people are moving from one state, or rather I will say from surplus labor state to deficit labor states in our own country because of the differential demographic transition. And if we want to do anything about improving their lives, so the mental health and psychosocial counseling should be a part, for a normal activity at the time when they start from their place of origin, and as well as, when they reach there. So thank you very much. I think these are the good learnings which we can integrate further, and we can bank on you to develop something on those lines as what you are doing for adults, adolescent and young people.
Thank you so much.
So thank you, Dr. Aparna. Thank you very much. And now we have a representative, one of the panel member from Jan Sahas. So Prateek. Okay, so from your perspective, so we would just like to understand your own experiences about the outreach strategies which you use to improve the vaccine confidence among the migrant workers. So what was those, and what were the challenges which you faced? Thank you.
Right. So thanks for that. So when we started our work on vaccination, we were facing two issues. One was regarding awareness, and second was regarding access. Awareness, again, we all have heard there are negative perceptions, misinformations that were there. So we started reinforcing positive information among the people. We collaborated with the PRIs, we collaborated with the Asha Anganwadi workers, local level stakeholders, local influencers, and tried to talk to the communities about it. Another thing that we did was that we have our CBOs, community-based organizations, and volunteers across source and destination locations. We talked to them, we provided them right information about vaccination, and that's how it reached the community. Again, some things that helped us were visually attractive techniques. So we used IC materials. Again, we used folk dances, street plays a lot to provide information to the people. Especially if you see certain areas of Madhya Pradesh, which are tribal areas, their folk dances were very helpful in communicating the correct information to the population. In terms of access also, there were challenges. There were vaccines were not, obviously when, so there was a fear, right? There were two kinds of fear. One, the fear was of COVID. The second, the fear was of vaccination. So the fear of vaccination, we were able to cover through these aspects. Second, the fear of COVID, we tried to talk to the workers. There was a fear that if we go out, the workers go out, they bring in COVID to the household, right? So such fears were also there. So we tried to talk to the community. We tried to, promote COVID appropriate behaviors, because guards were all down. As we know, like January, February, March, guards were all down for the communities. So we talked to them about COVID appropriate behaviors, and this is how we tried to promote vaccination awareness.
Okay, good. Suppose if we have to give one recommendation, that how do we reach to this last miles and improve and tackle this misinformation? So what would be, and what kind of coordination you will like to have with various stakeholders?
Right. I think I feel the government reached out very well. Both central and state governments were proactive, and they reached out very well to the population, and the collaboration was very effective, whether it be with the CSOs or other collaborators. But certainly, if PRIs and local bodies, they would have been trained on time, and they can take these things forward. So I think a key role should be played by the PRIs at the local level, Panchayati Raj members. Secondly, identifying those key players, local influencers, CBOs, SHGs. I think some of our colleagues already talked about it. So I think collaborating with them also is very important to take the information to the last mile.
Thanks. Now I move to Dr. Shantanu. Few questions, and then Anjali, I will come after that. Shantanu, as you know that for migrants workers, how do we cater to the specific needs of these migrant workers, given their size and also the variations, diversity among the migrant workers, so that we should develop a more sustainable and customized approach for them. So what's your take on that?
Hello. Yeah, thanks, Sanjay. Yeah, I mean, COVID-19 had its challenges. I mean, some of them are specific to migrant workers, and some are, COVID-19 vaccination had its challenges. Some are specific to migrant workers. Some are inherent the vaccination process, given the scale of the problem. I mean, the way it started with the CoWIN app, etc., it seemed like that the digital divide is going to be a major hindrance towards the equitable coverage of vaccination. But with time, we have seen that there are a lot of innovations, introduced, a lot of customizations that you were asking for. Has been introduced, like more sort of walk-in vaccination centers, more and more near to home, non-health facility-based temporary vaccination centers, and so on. So because of those things, I think access to vaccine has improved, definitely for vulnerable populations like migrants. But there are 2-3 issues that has been discussed since morning, and even Binay mentioned also, like specifically for migrant workers. Phone number, mobile phone is now almost universal. So I think having a mobile number for vaccination is probably not that much of an issue, but maybe having a valid ID card often could be an issue. And for that, we heard that there are solution of having a key facilitator based vaccination has been introduced. But there could be concerns like suppose I get 1 dose of vaccine in one state with one key facilitator who have organized vaccination for me, then the migrant worker moved to another state, and then when we try to link it with the first dose of vaccination, it may be difficult given the different, because if we can't provide the ID and the phone number of that key facilitator, that could be a huge problem. And the second problem is the language issue, like as has been discussed, like a person from North India or West Bengal in a southern state could be a major problem to get information about where to go and how to get vaccination, etc. So that's why it is very important to identify migrant workers and provide solution to them. And for that, we all know that we don't have reasonably good data registration of migrant workers, etc. Those are the very basic things that needs to be improved in order to identify these people and provide proper guidance to them during such a situation. And overall challenge which affected at least initially, which affected the general population as well as migrant workers is the hesitancy part. I mean, if we think of the planning stage of government of India, and I mean, given the scale, probably that's nothing could have been done, but all the focus were mostly to handle the supply side challenges, how to use the vaccine storage facilities properly, how to use more vaccinators, train them, and create more vaccination centers, etc., so that we can address this problem of scale. Even if we have vaccination, that was also for a targeted age group. So that's why probably all the focus were on the supply side challenges. We didn't pay much attention to address the vaccine hesitancy issue at the beginning. I think that was, I mean, probably there is some documentation somewhere in the operational guidelines, but I don't think it was ever emphasized at the beginning, the hesitancy part. So I'll stop here and can come back later on other aspects.
Okay, you touched upon the role of data, and you will agree with me that we have a good data which will lead to better policies and programs. So just picking your brain on that, on the data issues, how can you think that the standardized migration data, if we have, how it will facilitate further for coordinated policy response, programmatic response?
Yeah, I see. I won't specifically comment on how to standardize migrant data, but just use of data. Just I'll probably better to comment on that, as I don't have much experience. Probably Binoy can handle that question better. But just to use of data on that part. I mean, see, today we are here talking about attending this event and talking about it is because we have a COVID app. We were able to get timely data. I mean, even many other events on vaccination were possible because of the access to timely data. I think that was a great innovation to have this data readily available, the coverage data readily available. There are challenges with COVID. We get data by vaccination dose, by gender, etc., but we don't get data as a combination of two factors. Okay, so that's a challenge I found while using COVID data. But again, coming back to the hesitancy part on the use of data, how it could have been handled. I mean, see, we all, some of the hesitancy, I mean, I looked at some data which tells that the vaccine safety and concerns of side effects are the major concerns for vaccine hesitancy. I mean, Dr. Pal also had some ideas on how to handle that. But one way to handle this, we all get to have either experienced or get to hear from our friends or acquaintances some story about some severe side effects someone experienced. Okay, all these are not necessarily false. We can't always put it under the rug of misinformation. I mean, some of them are actually true. But how to handle it? I mean, but if you think of the percentage of vaccination cases, they probably don't account for even less than 1%. Probably 0.5%, or I don't know, much less than the number, which is much lower than the case fatality rate or case positivity rate, if we think of. Okay, so if we can use our AEFI data more efficiently, just to show that the level of, or the proportion of severe adverse events following immunizations are much less than then, as I said, like the test positivity rate or the case fatality rate. That would have been a better way of handling this distrust and hesitancy part. And for that, it's just not that we don't use our AFI data properly. We also have to build a robust AFI system. I think that could be another way of handling this mistrust and the hesitancy. I'll stop.
Okay, thank you very much. Now I move to our another panelist, Anjali ji from Disha Foundation. So with your experiences, what do you think, what is the most effective awareness generation technique to reach out to the migrant workers during this pandemic?
Sure. So, yeah. When we started working with migrants on not just on the vaccination, but also on the COVID related information and increasing awareness for the COVID appropriate behavior, we worked with different sector of workers, and I'm just sharing my own experiences. It's not kind of a standardized format for generating awareness. It can be varied from group to group. But when we started with diverse groups, including domestic workers, in NCR Delhi, or the construction workers. In Maharashtra, we work with the agriculture workers, construction workers, even the hospitality sector workers. Or in Goa, we work with the fishery sector workers and even the hospitality sector workers. So what we learned while working with them, and it was not just during the first wave, but mainly during the second wave. The one-to-one or the group session were not very effective for conducting the awareness because of the restrictions and also the fear of getting infection. So we identified and we also trained the peers among the migrant workers. We call them Shramik Mitras, and we trained them on the COVID appropriate behavior and also on the vaccination part. We identified such workers, and those especially who have smartphones or who can use the online tools such as Google Meets. And to our surprise, it became very successful. It worked for us. We also created WhatsApp groups of migrant workers, and especially for the IEC, it was understood that the readable information is not very useful. Nobody reads it. So instead, the video messages are more appealing and they are more easy to understand. And that time we realized that we should also have a regional language material, not just in Hindi or the local language. So video was, I think, very effective means to reach out the workers. But besides the IEC material, the modes through which we could reach out was the online tools, Google Meet or the WhatsApp networks. And of course, the foundation for that was the peers among the migrant workers.
Okay, so one of the things, it is a good way to reach out through peers and use of technology. How about your experiences to deal with any stigma and so many things? So have you also come across, and if you have dealt with, so how, and your experiences on that?
Sure.
Please.
So while working on this issue from first wave and till we moved to the second wave time, we conducted a rapid assessment study in almost 6 locations of India where we are working. That was NCR Delhi, Maharashtra. We had 3 cities, Nagpur, Ahmednagar and Nasik. And in Goa, we covered both South and North Goa. And our sample size was 1,000 workers, nearly 200 workers from each location. And again, we covered from diverse sectors, including fishery, domestic, construction, and hospitality sector. So during this survey, we found that, the workers do have myths, and the myths were mainly coming because they don't have the sound information about the COVID, as well as especially about the COVID vaccination. And the common myths were they can get weakness after getting vaccinated, or they can also face the fertility related issues. Especially in Nasik, there was an incidence. We have a Maharashtra colleague, he may remember that. In Nasik, there was a person, and after having his first dose of vaccination, he started attracting the metal particles on his body, especially the coins or the steel vessels, and there are lots of photos on the Google, you can see those. So after having that incidence, most of our program, which was taking off, it suddenly came down, and migrants got, bit apprehensive to take the vaccination. Then, of course, the public health officials stepped in and they visited that person in person at his home, and there was a report released that it is not a side effect of the vaccination, and basically it is nothing to do with the vaccination. There may be another reason, and that is under scrutiny. And again, slowly, it started taking up. But I think for combating or the working on the myths of the worker, I think again we took the help of peers among the migrant workers, basically training and minimizing their own myths first and then sending them as a messengers within the community. We also work with the religious leaders, especially the missionaries, to work around the myths in the community. And the third one was also working with the employers. I think it was a very important step, because we realized when employers started insisting that we need a worker, we can provide a job, but with the vaccination. And that time we saw a tremendous shift among the workers, especially the domestic workers. They themselves started coming forward and please do our vaccination. We want job. We want to come back. Likewise in hospitality sector, and every employer, almost at least the key service providers started putting a kind of a I will not say disclaimer, but kind of information that our workers are vaccinated, especially drivers or hospitality sector. I think that was a major shift. So employers' role was important in this scenario.
Okay, thanks. And I think we have got good inputs from all the panel members. And we are also now just over the time. So if time permits me for about 3 minutes or so, if any one of the panelists here, not compulsion that everyone should talk about, suppose if we just pose one question, what is one thing that we learned from COVID-19 vaccination rollout that should be implemented in either routine immunization of a health services program for the migrant workers or for any other services? Anyone, if you think one thing, and please be short.
Very brief, yeah. I would say that all the programs, all the public health programs should by default include the migrant workers, whether it is mapping or the delivery of services. And I think immunization comes first, but also all the public health services. Thank you.
Okay. Any perspective?
I think vaccination is a substantial investment in the prevention of diseases. So it is my humble submission to the Ministry of Health and Family Welfare that we have never charged for vaccines, and we are doing it now. The third dose of COVID is you have to pay. Sanjay, I think probably this is the right forum to submit a resolution to the Ministry of Family Welfare to make this third dose for free. We have never charged for vaccines, and vaccine is the best investment. Instead of providing medical care, hospitals, or even mobile medical units reaching to migrant workers. So if only people who can afford to buy vaccine are getting vaccine, that is injustice. So in the context of equity, probably this engagement could, as a outcome, could submit a request to the government of India on making this for free. That's the only summation I have. Thank you.
Okay. And I think there are few states they made it free, though the national government has. Any other perspective? Otherwise, okay.
Just adding to what others have said, I think segmentation is very important. Like we did for frontline workers. Similarly, I think migrant workers have multiple vulnerabilities and occupational health hazards, especially related to lungs. If you see silicosis, TB, construction workers are very vulnerable to that. So I think segmentation is important, and we could have used databases like now we have eShram also, or digital health ID, how such databases can be made inclusive of such things, indicators where we could identify potential threats to workers and maybe then prioritize them in future.
Okay, thank you. So I think we come to the close of this particular session, and I just hand over for the closing remarks from the chair.
So we learned a lot from all of you. There are various kind of experiments going on in the world, like as you say that it should be made free. And in Japan, there was a study that willingness to pay, measure the willingness to pay, because if you throw away something at free of cost, people don't value it. And then, various kind of things you can look at. And somebody is saying that, okay, you reward them for getting vaccinated. So you can do small scale experiments and on this, and then you can throw up the results of how people react to these kind of experiments. And that will be useful for future kind of, if the next time something happens like this, then this is the lessons you should draw from this kind of experiments and document it. Yeah, that's important.
Thank you. Thank you to all the panelists. And now we just close this. Thank you. I don't know if we had any questions or something, but the time is one question. Okay, just allow the floor for one question. If okay.
It's not a question, but I wanted to share the experiences with COVID vaccination and what we did in different parts of the country with unorganized sector workers, especially the industrial workers. The success of this COVID vaccination lied in 2-3 points. One, of course, the strong, huge, robust governance mechanism that appeared. Second is the national level campaign. But with reference to the COVID vaccination to the migrant workers, of course, there are lots of challenges. And we, the community-based organizations, the NGOs that have very closely working with these migrant population, floating population. And when it comes to, you know, the success, of course, there are things like it requires to the community to be mobilized, bring them to the vaccination centers. And of course, the last thing is that from the supply side, of course, everybody has worked at the supply side, but the planning, the logistics, and understanding the challenges, what the frontline workers are with the mobile population, the migrant population is, of course, that is required. So we work together with the frontline workers, making them understand, at least training them, how should we organize in terms of creating mobile booths at the urban slums, the industrial work areas. So that we did in different parts of the country, like Aurangabad, here in Baddi, Nalgad areas, and we provided more than 3.5 lakhs COVID doses with direct support from the Department of Health at these districts. So the success lies definitely in when you work together with the department, the line department, and the community-based organization, and of course the local representatives. That is my take. Yeah.
Okay, thank you. And I think we are just overrunning the time, so we just close it. And thank you very much. And we just close this. Thank you.
And now we come to another very important subject, and that is the employer's role in COVID-19 vaccination for migrant workers. This session is chaired by Mr. Sachin Joshi, Head Facility for International Cooperation at ISID, and it's moderated by Mr. Amit Chaudhary, National Project Officer of IOM. The industry stakeholders on the panel are Dr. Shabnam Singh from CII, Colonel Mahendra Singh from Maruti Suzuki, Dr. Chiranjeev Bhattacharya from UNDP, and representatives from PhD and ASSOCHAM. I'd request our panelists, chair and moderator to please come up on stage. And I request each of our speakers to restrict their remarks to 8 minutes or less. Thank you.
Right. Good afternoon, everyone. I'm Sachin Joshi. I am from UNIDO. I look after the facility for international cooperation on inclusive and sustainable industrial development. I want to thank the organizers for inviting me, to chair this session. And it's, would be an understatement to kind of say that this is a very important subject that we are discussing. I'll just make a few remarks before I hand it over to Amit to moderate the session. I think the role of the employers in achieving, good scale of vaccination is well noted, and it was referred to in the earlier session as well. But I think we still need to dissect the employers or the private sector into different segments and categories. My own observations are that there have been stark differences between how the migrant workers were treated and dealt with, not just during the vaccination, but also during the first wave when COVID hit, actually. There were huge differences between the two, informal sector workers and the formal sector workers. That actually shows that, there is a huge capacity gap also between the employers in these two sectors. So that is one point that we should keep in mind. The other related observation is that when we actually move to the second wave, around which time also the vaccination actually kicked off, the motivations of the employers, again, across scales and sectors, the motivation of the employers to get their workers vaccinated were very different from their motivations to handle the migrant workers during the first wave. Of course, here the motivations were actually quite favorable to the resilience of the business and bringing business back into action, where you really needed workers to be safe and have a safe operating environment for everyone. While everyone on the panel will of course get into what each one of them did with their members and in their networks, but there are a couple of more observations is that when I look at it from the United Nations guiding principles on business and human rights, the pandemic actually showed, and even to some extent the vaccination drive showed that there were considerable gaps between what the principals asked the businesses to do and what the businesses were actually doing. I wouldn't entirely discount that the businesses were innocent, but in some cases, yes, that was indeed the case. And finally, I think there were very important lessons that were learned from COVID and its vaccination drive, which are not only limited to a health crisis. You could actually translate a lot of the lessons learned and the capacities which have been built now into other crises where a similar migrant worker crisis could also emerge. So with these some initial remarks, I hand over to Amit. Thank you.
Thank you, Mr. Sachin. As you know, this is the last session, and the role of employer, it always have a sort of a very important stakeholders of the society playing a very important role when we talk about reaching to each and every migrant and in the context of COVID pandemic and reaching them with the vaccination, how we can include everyone and reaching them through our effort. And in that context, private players always play such an important role. Today, what we are going to discuss about what should be those prosperous thing through which we can connect with industries and private players and help the government in their initiative to reach each and every person remotely sitting away from us. We have today Dr. Shubham Singh from CII. Welcome, madam. We have Colonel Mahinder Singh from Maruti Suzuki. Welcome, sir. We have Dr. Chiranjeev Bhattacharya from UNDP. Thanks for coming. We have also Mr. Praveen Kern from ASSOCHAM. Thanks for coming and giving some time to join us from your busy schedule. I was just going through one of the reports which FICCI and EY did a couple of months ago, which was saying the requirement of a health professional to the tune of 1.3 lakhs to 1.4 lakhs. We require vaccination centers to that number. And also we require health professionals to the tune of more than 1 lakh. So you can think about the demand in the market and how the private players can play a big role in connecting with the efforts of the government. So in this session, what we are expecting is what role we can play to make a bridge between demand and supply. What we have been playing till now, how we have assisted the government initiative through our effort. Then role of the private player from learning drawn from various states, the efforts they have made. I know different big players, big corporates, they have really done remarkable support to those migrant workers when everything was closed. Still, they have given space to them. But in the vaccination front, the success, what we have spoken throughout the day today, they have really played a big role. What role they have played, if you can share those points with us. Also, any sort of potential management models you have played or you are expecting to play and connecting private and public sectors across different stages of the value chain. Because when we are speaking about the corporates, we also need to consider about the supply chain players who are playing a big role when they are running their own business. And when I continue with this discussion, I see this discussion through the lens of three major points. First is conviction, sharing resources and information to educate the workforce, what the role you have played from your end. Then the second one is the senior leadership, how they have made their own presence felt by the industry and as well as while connecting with the government effort, the management, how they have reacted on that particular point. On the convenience, sharing practical information on different initiative from your place, from the industry point of view, from the platform point of view, and then offering vaccination. It may be on site, it may be reaching to people remotely sitting away from your industry area, what sort of initiative you have taken, and costlessness, because getting into the vaccination, even the migrant workers, and they need to go for 200 rupees, 300 rupees, or 400 rupees. And sometimes it is very difficult for any migrant workers to even go for that cost to bear. So industry, whether they come up with some initiative or model, which we can highlight here. Continuing with this particular effort, I would start from Dr. Shabnam Singh. Madam, I have two questions for you, specifically in the context of initiative taken by CII. Has your association been able to identify industry-specific good practices regarding COVID-19 vaccination among migrant workers? And what are the strategies adopted for better public-private partnerships in the COVID-19 vaccination programs? If you can highlight, you have around 8 minutes to speak out. Thank you.
Thank you, Amit. And I thank the organizers for giving CII an opportunity to be able to share with you the work that we undertook and the steps. So firstly, I'd like to share with you that CII in its role today considers itself a developmental agency. And in that regard, our role with the industry is to see how we can support both the businesses as well as government in its developmental journey. Now, the questions that you have, the forward that you have given, Amit, and the questions that you have poured are enormous, and it's a lot of work in it to be able to say it in 8 minutes. Having said that, I'd like to share with you that in June 2021, we released this document from CII. It is available on the web, and this essentially answers all your questions, and each point is very beautifully illustrated. But I'll take out some salient points for you and share with all of you. So this was the CII, it's a compendium of CII's response to COVID management and mitigation, and it includes the questions that you have asked for. So I'll leave it here. You all can reference it in detail later. So basically, our journey with COVID started with way back in December of 2019. We were embarking upon SIAM, which is an initiative of the automobile industry and CII in automotive work. About 650 Chinese companies had come into India to display, and that is where we got sensitized to this. We immediately started working with the Ministry of Health and Family Welfare on this process, even before it had actually hit our shores. Because in a manner of speech, our sensitization and response management started at that point. So what is it that we did? The first thing that we did was we had a task force on healthcare co-chaired by Dr. Naresh Trehan and Dr. Naushad Forbes. And why did we do this? Because we sensed immediately that this is going to require a multi-stakeholder engagement. It's not a vanilla product where only healthcare will be required. So it was very critical for us to get the entire industry leadership team into the room. And with that in place, we started working on a war footing, making subcommittees into this. And we even gave support to NVAC, getting information from the rest of the world, making coordinates of manufacturers, putting on a digital platform with the government of India to be able to supply masks, identify the manufacturers here, identify areas where we needed to import equipment. We started importing it. We started working with Maruti Suzuki, and Colonel Saab is here on the ventilators from DOT. So it was all done in tandem only because we had a multi-stakeholder commitment and engagement. So what I'm trying to emphasize is healthcare is no longer the domain as well as the purview of healthcare providers. I think that, to me, and CII is the most important take-home message. It is the responsibility of every individual, and it cuts across all sectors. That is what our learning has been. And we have worked extremely hard in this. With specific reference to vaccinations, we focused on 3,000 companies in the mid and small enterprises. That was our focus because we already had the in-house commitment from the larger industry players. So that focus was there from day one. And it was not only sensitization, but even sharing with them where to get the vaccines, getting the aggregation from them of how many are required and not limiting it only to the employees, but even their families and surrounding community. So we started fanning out. We have a very robust community project around our 68 offices. And again here, interaction with the pradhans and the community was extremely critical. Also, we realized, and this was March of 2020, when we realized telemedicine is an extremely important component of providing care. We worked with Niti Aayog in the release of the telemedicine guidelines so that doctors could be empowered to be able to provide for care. Till then, there were stumbling blocks in that. The other piece we worked exceedingly hard was in providing eICU services and training services for healthcare professionals. As you very rightly pointed out, the demand-supply gap of healthcare professionals is intense. So that was our second area of focus. Having said that, on a long-term basis, we work with the Ministry of Health and Family Welfare on the TB eradication program. We are the partners for Ministry of Health and Family Welfare. So sensitization of state governments, understanding individual state government issues in challenges of operational rollouts is an area where we leverage our multi-stakeholders to be able to provide for solutions. As far as Make in India is concerned, I think our relationship with Suzuki and other Mahindra and Mahindra in providing ventilators, mapping out what is required specifically in India for this purpose, in harnessing testing capabilities, making sure that the price point at which states can procure, and I heard the earlier speakers say that it should be provided for free. Yes, the consumer can take it for free, but somebody has to pay for it. And when you have to pay for it, you have to be sensitive to the cost of procurement. So our endeavor is to work with industries and see how is it that we can bring these price points. All the vaccination companies, all the healthcare provider companies were supported by CII in their endeavor to make this happen. All these are, as I mentioned earlier, all these models are in this compendium. If you want any further information, we'd be very, very happy to provide for. Lastly, in the interest of time, as you said, sir, it's very important to understand the span at which pandemics are going to hit us worldwide are no longer going to be once in 10 years or once in 100 years. They're going to be within 3 years, 5 years. You don't know when it's going to hit. So being prepared for pandemics, training the companies to make it happen, to have on-site health officers, sensitizing human resources, to have individuals as well as cheerleaders, peers within their organization to handhold other members in their companies is extremely critical for us. And we are constantly working on this, sensitizing them and making sure they understand what health is and how do they approach the challenges of health. We do not leave the community aside. Our foundation supports this, and we have 3 pilot projects working as to how it needs to be tweaked. What is good for today may not be good for tomorrow. And therefore, making sure it's contextualized constantly is our endeavor. Back to you, Amit.
Thank you, Dr. Shabnam. It's quite true. Is sometimes very difficult to cover up all the activities which you have already taken initiative from your side. Such a big organization you are having, but it's really appreciating to hear from your initiative, and I'm sure in days to come, with your support, all other stakeholders, what they are doing will be coming together, and we can take the initiative forward towards a bigger goal to achieve for these migrant workers in the vaccination part. I would next reach to Mr. Praveen Kumar from ASSOCHAM. Sir, I have 2 questions for you. First is what and if any directions were delivered to employers or the companies to overcome such hesitations or barriers not to go for vaccination, because that is also one of the case where we found that people were quite hesitant in reaching reaching to those destinations or to those places for vaccination. That is one. And again, the same question, what are the strategies adopted for the better public-private partnership in the COVID-19 vaccination programs? Because it is highly essential in the context of we always look towards the government for their initiative and therefore for their role. But when it comes to us, what effort we have made to reach them and then aligning with their effort and make it a success for the government as a sort of contributor. So these two questions, over to you, sir.
Sure, thank you very much. So first of all, I'll introduce myself. I represent ASSOCHAM right here today as a member to ASSOCHAM, but I do not work for ASSOCHAM directly. We are in panel with them. I in fact feel that I could have represented CII also as a member, because we are the member to CII and we have joint works on COVID responses for being a representative from actually Minda Corporation Limited. So I take care of the sustainability CSR and ESG programs for Minda Corporation Limited. Well, to answer to your question in my time slot, I'll narrate you a story. How did we respond to it? Avashyakta Avishkar ki janani hai, that we all know. Necessity is the mother of invention. And we all saw this pandemic as a very new subject to introspect, to react, to understand, to find out the solutions for the problems. Generally we identify a problem statement, and we deliberate, we analyze, and then we find out the solutions to those problems. Well, in this moment, first time ever, the humanity get to know that you just have to quickly respond with the problems, with a set of problems that you are facing. I yet remember news में वो आया था, आज से भारत में संपूर्ण लॉकडाउन किया जा रहा है. Our Honorable Prime Minister's voice, this echoes everyone's, this is there with each one of us. And post that, the migrant laborers, they were all on streets and people had to act to it. That was the first point where, as a member to ASSOCHAM or CII or as a representative to Minda Corporation Limited, we reacted that when we saw these migrant laborers going, the very first thing and the most common thing that everybody did was distribution of the cooked food items. We started with that, the very, very basic. I don't want to get into any sort of analytics to this, that whether it's benefited, it's not benefited, but we thought that is the need of that time. Then further we added, once this was going on, there was a full-fledged lockdown. People were not having ration to prepare food, and majorly those people, those who are vulnerable. So we targeted some of the vulnerable groups, people with disabilities. We worked with ASSOCHAM and CII both in Delhi NCR to reach to them. We reached to close to 5,000 persons with disabilities and provided them ration kits so that they sustain at least for a period of 1 month. We went to Jammu Kashmir along with Indian Army. Colonel Saab, I'll be very happy to tell you about the Sadbhavana program, through which we could reach to the valley and could do the similar program there. And the third was the leprosy affected people with leprosy to whom we have reached in Uttarakhand. And then ration distribution took place. The next thing was the plasma. Then it was accepted. Till that time, it was being accepted by the medical, hospitals and all that. We volunteered for that, and close to 700 plasma donations has happened in Maharashtra state by us. Till the time it was allowed. And all the volunteers, they were from the panchayats, they were mobilized by the Gram Pradhans with our corporate social responsibility team, our own people. We have close to 16,000 people working in our organization. They were also volunteering for it till the time it was allowed by ICMR. We stopped that. After that, healthcare need was identified. Then the accessories, which had to be modified as per the need of COVID responses. We worked on that. JLN Hospital, Safdarjung Hospital with ASSOCHAM, we worked there. Then it comes to masks. Everybody needed masks. We got into our CSR program again, asked our women to stitch masks, and we started distributing it with the reach of our pradhans, panchayat representatives, our stakeholders, and we did a distribution of close to 1 lakh masks across different locations. Then it comes to the COVID care center, which was developed in Gurgaon through ECMA, CII, and we are also one of the members to that. So that was, a long-term plan for addressing the requirement of hospitalization. We did that. Finally, it comes to vaccination. The first vulnerable group, again, we identified was the persons with disabilities, and we did it for 5,000. We facilitated a vaccination for 5,000 persons with disabilities. Those who are working in our organization, those who are not working in our organizations. We worked with Ministry, Department of Social Justice and Welfare to get them to the vaccination places, because reaching to those places was difficult for them. And we have to ensure their accessibility to those locations for vaccination. That support was extended by our team. And then one point of time, we were the first organization to declare that we will be vaccinating all our employees, 15,000 employees across India, free of cost. And we did that. So that was the overall journey. Well, to summarize to the second point of your question, we also have been supplementing to the government programs. I'm looking at my time. Arogya Health Kit, awareness about the government program, benefits of various insurance schemes which comes through the government. We made people aware about that. Behavioral change communication for the people who are working on the shop floor. They were very much reluctant about vaccination. Lots of drives were done where we also invited people from the government medical department, and they did counseling for our people working in the shop floor to have vaccinations so that they can actually be protected. To end within my last 2 minutes, well, what can we do? To second part of your question, Amitji. Collaboration. I feel as in the way forward for all of us is collaboration. We all cannot do everything. So each one of us have certain set of deliverables out of this entire set of works which is there. It's just not government, सरकार को करना है, नहीं ऐसा नहीं हो सकता. हम कह दें कि हमारी जिम्मेदारी नहीं है, नहीं हो सकता. हम सबको करना है. So what role do I play as a corporate? I haven't reached to my people in the shop floors. I'm present in the remote locations. So why can't I extend that facilitation from that band of the corner of the country to the government with the government departments, health department? That's something. Dividing deliverable is important. That's second. Third, which I feel is leveraging strength. I'm good at something, you're good at something. Our NGO partners have been excellent in reaching to the people at the grassroots level. And then we can exchange our, expertise with that. That's third. Fourth is the application. If there are some good models, we need to learn from Maruti, from CII. There's a compendium all together. We can look at these good practices, and if they are applicable, we can replicate it. And finally, to sustain, that's my 1 minute, 59 seconds left. So thank you very much.
Thank you. Thank you, Praveen, for sharing all those good initiatives and bringing different stakeholders together to take the things forward. Now I would reach to Colonel Mahendra Singh ji. It would be a different perspective when we speak with the different industry platform, their approach, because they need to cover and connect with their members and ensuring good practices to be continued and how they can support the government. If I come to industry individual, their way of working may be a bit different. So I have two questions for you, Colonel. First is, what roles are employers playing to support COVID-19 vaccine adoption among employees, factoring in conviction, that is vaccine confidence and convenience, ease of access for the migrant workers in their facilities? That is one question. And second, what kind of steps or guidelines from the government or industry representatives would employers benefit from to help alleviate anxieties and uncertainty surrounding COVID-19 vaccination, and does leading by example help? What is your opinion and your own way of your thoughts, if you can express it. Thanks.
Thank you, Mr. Amit. Can you hear me at the back, please? Good evening, ladies and gentlemen. COVID-19 was a curse. We all know that. And it was difficult for all of us. We all know. You have something written there, no one to be left behind. Our chairman gave us clear mandate. We don't know where the vaccine is, but everyone has to be vaccinated. When he said everyone, it was not only 60,000 employees that we have. More than 60% of these 60,000 employees are migratory workers. They come for 6 months, go back and stuff. Also, we have Suzuki motorcycles. We have Maruti Suzuki Gujarat. So all in all, and I must share at the outset, Dr. Shabnam, thank you very much for calling it out. I was singularly fortunate to be forming the COVID task force for the Maruti group, managing it in the beginning and managing it even now. I don't know for how long I'll manage it, but it's going on. So the first wave, nothing much happened as far as the lives were concerned. There was a bit of complacency, and a lot of confusion going around. So vaccination hesitancy came from there. Nonetheless, when vaccines were not available, we ensured that we got it from both institutes. In fact, when we got the first lot as a corporate, paid fully for it in advance to Serum Institute. We got these through 2-3 hospitals, had all camps in our own campuses, and ensured that everybody got vaccinated. Yes, there was some vaccine hesitancy in the beginning, but we employed very different methods. Firstly, the cost of the vaccine in the beginning was very high. It was more than 2,000 for Covaxin and 1,200 for Covishield kind, even though the government rates were much lesser. But we did not see any cost. Whatever was available, it just came in. So how did we incentivize people? Firstly, we gave leave to everyone, whoever got complained about, any after effect. Also, we said, we will give it to you wherever you are. Doesn't matter whether you are in the factory or your families are elsewhere, we will give it to you there. Also, in case you cannot go there, but you have a hospital where they're charging very high. And mind you, in the beginning, they were charging very high. We said, pay them, doesn't matter, we will reimburse you, including the cost of transportation till the camps. So we did a lot. And industry knows it, everybody knows it. There were times when we felt, why are we doing it? People are not interested. But my target used to be, we have to finish 100%. So in the first two rounds, first two doses, more than 1.35, 135,000 doses were administered, all free of cost. Now, you asked me the question about migratory, I won't call them laborers because they're all skilled workers with us. Most of them come back, but after 7 months, they do go back, and they come from rural areas and places where a lot of confusion and stuff is there. We set up our teams to go to these clusters, educate them, tell them. We ensured that in the factory, these people are given examples. Everybody gets vaccinated. And those who did not listen to, in fact, there was a circular from the government that anybody who is not vaccinated would not be allowed to come inside. So we used that as well. So all put together, I can very safely and very happily tell you that 99.9% people, just about 150 people have not got vaccinated out of these 60,000, only because they have medical emergencies and they are not taking chances. But there are about less than 10 who just don't believe that they can take it. So that's where we are as far as the vaccination is concerned. The second part of your question, which is actually very interesting, is, and we have been thinking about it, how can we make sure that people receive it well? In the second wave, we lost lives like hell. I'm singularly, again, unfortunate to have lost my mother even before the vaccine could come in. So both the mothers. But After that, the vaccine hesitancy just went off. And we were entrusted with another problem where people said, we want to get vaccinated fast. So it was need of the hour then. We managed it. However, certain lessons, like we failed to convince people, we as a nation, I must say, vaccine is a chemical. It has to get inside your body and does some work. Now, we are very familiar and very, at ease with Ayurveda. But I don't know why we could not convince people that this is also a kind of chemical, just like, Ayurvedic medicines have a chemical and it goes inside your body, doesn't, has any adverse effect. All that thing was not done. So it was still considered a foreign material, a chemical, not proven. God knows what will happen to you. I think as lessons learned going forward, we should be able to give the comfort to people to what they believe in. We are very comfortable with homeopathy or Ayurveda. We must dovetail that aspect into this. And second most important one is advertisement. Government went whole hog in doing a lot of advertisements, but practical kinds of advertisements where people will get actually impacted. It is possible. That should be done. And like I say, I was talking to somebody in the beginning, it was something new. Nobody knew anything about it. So hit and trial most of the times, and we did whatever we could. Finally, just one thing, corporate world, CIIs, ASSOCHAM, CIM, of which my MD is chairman, all these people came whole hog, and so did the government. I think in my lifetime, in the last 62 years, I haven't seen this kind of action having done by the government, our government. I mean, there are many governments across the world. I'm sure they didn't do as well as we did. So kudos to all of them, and really a lot of lessons to take home. And this conference itself is a very good sign that we are on the right path. So thank you, Amit. A lot of time left. You can have your own questions. Thank you.
Thank you very much. And it's really appreciating to note that the statement I really like is when you said, instead of expecting migrant workers or the workers to come to you for the vaccination, you reach them. And that should be the objective from all of us, different stakeholders. Unless they are coming together, it is very hard to cover each and every person of the society. And that is really appreciating. And in the last one, also the point you said, the entire industry, fraternity, they came together to support government initiative. And that's why the result we can see. And we are being applauded not within India, globally we are being appreciated because of our initiative. And everyone is reaching to us to know our own good practices. And that is really appreciating. Now I would reach to our colleague, Dr. Chiranjeev Bhattacharya from UNDP. And that experience would be a bit different from what we are talking here. They have done considerable research on vaccination, connecting with people. My question would be, because this is specifically meant for industry and the industry platform and the research you have done. So I would like you to connect your initiative and your findings with the initiative of the industry. Two major questions for you. With the lessons learned during COVID-19, what types of strategies and tools can employers utilize to focus on health equity and health education amongst their employees? That is first. And second, what kind of steps or guidelines from the government or industry representatives would employers benefit from to help alleviate anxieties and uncertainties surrounding COVID-19 vaccination? And it is based on your findings. I would like you to connect with your findings with these two examples. Thanks. Over to you.
Thanks, Amit. And first and foremost, thank you for welcoming, inviting UNDP to this conference. And I would like to congratulate IOM because it's sort of a unique platform. Generally, we public health professional meet for a health specific conference, whether it is on immunization or some disease control program. But here we are focusing on the health of a particular type of population or a marginalized population. And from our UN perspective of reaching the sustainable development goal, the main underlying principle is leaving no one behind. So it is very critical and really a welcome step by IOM and NITI Aayog. So now to go to the question, and congratulations to all the esteemed panelists before me. I think the primary highlight of the success of our campaign for COVID-19 vaccination, or per se to the COVID-19 response, has been the cohesion and convergence or collective efforts of multiple stakeholders, because otherwise it would have not been possible, because we are talking about emergency or a public health emergency which comes in, say, 100 years. So it was unprecedented, and our country was able to respond to it in an effective manner. Now, why I'm talking about this unprecedented situation is that we all know that because of this unprecedented emergency, a lot of things were done which may not have been done in a routine way of life. So when we look forward and again to say that what are the good things that were done, as industry colleagues are saying, and what we have observed through our research or through our implementation of the COVID-19 vaccination, is the great convergence and collaboration of the government policies, programs, and guidelines by all stakeholders, including the employers of industries in the private sector, who basically took in all the guidelines, all the awareness program to their employees, so that they are aware and they are following those guidelines. So I think moving forward, again, this convergence has to be institutionalized. So whether we are talking of the organized sector, where we know that there are already public health facilities in many of the organized sectors, PSUs and all, which can basically take the learnings of the COVID-19 response and institutionalize those efforts. Similarly, for the informal sector, which comprises a huge percentage in our country, I think we have seen that association and professional bodies have played a critical role, and also micro level associations of communities also have played an important role. So we have to take those learning and see how that can be mapped and actionable or tangible actionable action plan, national action plan can be developed for addressing the health need of the migrant population in the informal sector. So these are two things. Coming to the third point was that we have been hearing since morning that technology has played a critical role in the success of the COVID-19 vaccination. And I say more confidently because we had implemented the COVID system for the Ministry of Health and Family Welfare. So that is an unprecedented success again. And seeing that we can cover the data of such huge amount, basically the whole of the country, the government is now assured and confirmed that this type of system can be taken beyond the COVID-19 vaccination. So in that context, just like to share some of the things which we will hear in a confirmed way in coming days is, as a first step now, the COVID system will be utilized in the routine immunization, so that the immunization program learned for the children and pregnant women. So the COVID system will be utilized for that. So in the next 6 months to 1 year, that will happen. So what was the current system is like, we are getting data, monthly data on how many vaccines were administered. And these are not individual data, not individual level data. Individual data is in the hard copy. So that is going to be digitalized. And this is very critical for the migrant population, because the discussion that has happened recently is because the Ayushman Bharat mission, which has the National Digital Health Mission also, they already are creating a unique health ID. So in that line, moving forward, ultimately in the COVID system, there will be unique IDs for each individual. So then a migrant worker, he can be anywhere, or he or she can be anywhere in the country, and they can be tracked and they can continue their immunization. And per se, these services will be extended to reproductive and child health also. So this service delivery and the issues of loss to follow up or access to services are going to be taken care of in a big way through use of technology. But technology, we always should remember, is an enabler. It is not the endpoint. So the effort from human and the processes need to continue as they are. So in that context, again, I will come back to what I was saying, the role that both organized and unorganized sector can play is basically develop an action plan where the specific health need of its workers or employees can be addressed. That include important component nowadays is the mental health, as Dr. Aparna from TIS was talking about. And basically, it is also seen that, as Amit was talking about research, so it is also seen that in India, we don't have a kind of structured knowledge on the health needs of the migrant population. Because of the unprecedented situation in COVID-19, a lot of focus has come. But once the COVID, hopefully COVID will wane off in few so near future. So we don't know. So basically, investment should go into research to identify the specific health needs of the migrant population. And as again, I will go back to Dr. Aparna. She was mentioning that within the migrants, again, there are other layers of marginalization. For example, a migrant woman or a migrant woman with disability or a migrant belonging to the LGBTQ or some community. So that type of multiple layers of marginalization are there. And then that may have different types of health needs and health accessing behavior. So that need to be studied. And also the service delivery model. As our previous panelists have said, that the outreach model may be a good model for service delivery to the migrants. So again, that has to be established. And the one model that has been talked about in majority of our public health program is that, especially for this vulnerable and marginalized population, is that because of the challenges, because they are in informal sector, they may not be able to come to hospital frequently, their health seeking behavior is poor. So they are talking about flexible hours of service delivery. At the same time, they are also talking about integrated service delivery, basically a one-stop service, so that one day when they are coming to that health facility, they should be able to access a gamut of services, so that that can be taken care of, and they may not come for the different things to different places. So that service delivery model also need to be considered, especially in informal setup where there are public health facilities. And I think CSR funding can be a important, useful resource for conducting research in all those areas that I have mentioned. I think mostly these are the points I wanted to highlight. But I would like to end by saying that the will and the commitment from all that was there during the COVID-19 response, that will again be an important factor. Of course, we have been able to strengthen our public health system during the COVID response, so that will be an advantage. So I think I will stop here. Thank you very much.
Thank you, Dr. Chiranjeev, for bringing and connecting the initiative with the technology and the technical aspect which you have used in your research as well. And I hope, and that's the claim from our side as well, how we can come together to take this initiative forward. Before I hand over to our chair, I would like to open the session to everyone. I can see a couple of hands are being raised. I would request my colleague to raise them to have their question.
Hello, everyone, and thank you especially to our panelists for a very interesting discussion. I'm Namrata. I'm from labor rights research organization called Equidem. So I just have a question for you, and I have a little bit of commentary first in terms of what we witnessed, all of us. So it's very apparent, obviously, that a lot of initiative has been taken on the vaccination front, be it from different government levels or from the perspective of employers, right? But as a researcher, I cannot help asking, throughout the course of this pandemic, where have we failed, right? Where have we failed globally? Like, why are people in this situation where they're bicycling 600 kilometers across the country? And by the way, I'm not just saying this in India, I'm saying this in a global context. And this is not to put the onus on anyone in particular here on the panel, on this room, but it's for us to think about this collectively, right? Because in a country with over 90% of the sector being informal and issues like a lack of contractualized workforce, we do see a lot of issues where there are basically gaps and questions like, where does a migrant worker get vaccinated? You know, we had so many questions which were really gray spaces for us. So my specific concrete question to all the panelists, for whoever is open to responding, is how do you see trends in providing healthcare to workers in the law and policy perspective for workers? Like, how do you see that evolving? You know, and if you see, like, one of the things that I thought was really good from this panel was talking about a holistic perspective towards providing healthcare, right? Like, so you're saying that we didn't just, for example, vaccinate, 50 workers, but we vaccinated all of them. We ensured that they all had access to vaccines. And for me, that's a holistic perspective. So if you're taking that holistic perspective with respect to health long-term, what does that look like in terms of law and policy? Like, if you're a company or if you're a government entity? Sorry, that was a very long question, but it would be great to get an answer. Thank you.
Thank you. Thank you. Anyone would like to take the holistic perspective we need to take? Anyone would like?
Yeah, but before I answer your question, did you say that why did we fail in this stuff? Did I hear you correctly? Okay, sorry. Yeah. So you are saying there was a failure on part of all over the world and we included, right? I beg to differ, ma'am. I think this was the most phenomenal success India could ever have seen. Please go and see the data. I see the data every day. America, Europe, Australia, New Zealand, Southeast Asia, everybody is still reeling under a lot of pressure. Look at how India has handled it. Phenomenal. Researchers must spend some more time to see the way we are spread out, the kind of health system we have, the infrastructure we have. Within that, how did we manage so well? And data is not fudged except the death data, which is managed all over the world. I don't want to go too much into it, but your one point is very valid. Has it stirred the hornet's nest? Has it woken up our conscience that we should be more careful about our health infrastructure? For the first time, we have seen something like, healthcare system at the national level for the first time. The number of hospitals, the number of AIMS institutes. I'm not spokesperson for the government, but I, as a free citizen, as a simple citizen of the country, I feel elated, excited, fully contented that we are in the right direction. I don't know how to answer your question. It may be relevant for all other countries who are still reeling under the pressure, but ma'am, we are doing very well. We should do even better with all the learnings we have. That's all I have to say, I think. Can I have this? Thank you. Yeah, please.
Ma'am, I would like to first empathize with the question that you placed here. Well, what happens is that every change has a cost. And while the entire world was changing, was adapting with this new requisite, there were people vulnerable. The migrant workers were one of them. Now, see, if you look at the benefits of the resources, typically worldwide, capitalism is yet dominant. If there is a flood, the person who has a house with 3-storied building would survive. Somebody who doesn't have it will not survive or will have difficulty to survive. I would not like to criticize the effort of either government or NGOs or anybody else here. Everybody is putting up the effort. But the quantity of the problem and the reaction time was that short that everybody was not possibly manageable. it cannot be a zero error thing. Yes, migrant workers have faced issues. It happened to them. Challenges were there, which were addressed also by individuals. I'm not talking about the government here. I know people who are outside their houses and distributing food to these migrant workers. That also happened. But yes, बाढ़ आती है तो कोई ना कोई तो बहता है, और ऐसा दुर्भाग्यपूर्ण उन लोगों के साथ हुआ जिनके पास रिसोर्सेज की कमी थी. I just wanted to add this.
Thank you. Thank you. I can see another hand. Chiranjeev, I would let you reply to his questions, maybe in a similar line.
So first of all, thank you so much. It's really been a great day. Spent time. Dr. Gunjan Taneja, I work with the vaccine delivery team at the Gates Foundation India office. So just a couple of things. I think we need to reflect on what has really worked well and what were some facets where we could have done better. And the pandemic has had different facets, the pandemic response, the vaccination, and possibly it's imperative that we also need to look at each of these sub-themes within the overall pandemic response differently. So the question is, coming to the topic of the day, the vaccination part, I think the two major aspects that we need to answer is, why has it been successful? If I limit myself to the vaccination campaign, and how has it been successful? So the why, possibly we at the foundation look at it from the 3 R's perspective: recognition, reflection, and then response. So if you look at the evolution of and Chiranjeev is sitting there, if you look at the evolution of the vaccination program, there have been instances where there have been issues, but those have been recognized. The procurement policy which changed, or even other, I'll not go into the details, but I think we have recognized issues, we have reflected upon them, and as a team we have responded. And that leads to 3 other words which I would like to bring to the table here, and those are the partnerships, the accountability. So each one of us taking that onus, that accountability on ourselves, and the transparency also which has been set up. So I think all of us deserve that pat on our backs. The government has been the lead, the fulcrum, which have brought together all the different stakeholders. There will be challenges, but I think the pandemic has given us those lessons and learnings as to how to sort of collaborate, coordinate, and complement each other better to overcome those challenges. But again, deep appreciation for the Niti Aayog, the IOM and UNFPA for the study and for bringing together all these different stakeholders whom we have been able to hear from the start of the meeting. Thank you.
Thank you. Thank you for your opinions on that one. I think we have.
Yeah, I just have a comment on the question by the madam was previous to that, because somehow comes in the area of work that UNDP does, because she was talking about safety net as well as vaccination. So thanks Gunjan for adding to the vaccination part. So what I was trying to tell was that from the global perspective, you have rightly mentioned that while we are giving booster doses, and that is very amazing being in the global south, because that is an exception in global south. So yes, that is happening mostly in the global north, where most of the countries are giving booster doses. But in the global south, I think a significant amount, I don't know the exact percentage, but it may be more than 50% are yet to receive the 2 doses. And that is mostly in the African continent, 2 doses of the COVID vaccine. And that is because that has been possible because, as everyone is saying, first and foremost, India is the pharmacy of the world now. So the production of vaccine is happening in India, and we have been able to not only support our whole population, but give to other countries. And that has become a best practice. That is number 1. Number 2, regarding safety net, what has worked in India, if you see, after lockdown, government of India has declared a series of social protection safety net initiative under the Pradhan Mantri Yojana, I think. So that was a huge declaration. And in fact, we as UNDP, and I am sure a lot of people in this room, in fact, industry colleagues were saying what all initiative they have done from their own side. So to basically implement that, as well as to complement that, The whole country had come together, and we personally, we had worked with the most marginalized, including migrant, people living with HIV, LGBTQ communities, and we have ensured that these social protection schemes that are declared by the government they are able to access it, because declaring is different thing, but getting the access and actually getting them is different. So I think multiple stakeholders from all sectors, they have facilitated this process, which again, if you go to a place like the African continent, which are mostly donor driven till now. So I think they must have struggled because the global supply chains has broken down after the pandemic. So because of that, all the price rise and non-availability of commodities was there. So they must have struggled in that. So my perspective was that these are the two areas where we have been able to sustain while being, although being in the global south, but some of the countries were not able to. And correctly said by all colleagues that from health perspective, only thing was that the second wave specifically was so overwhelming, so many cases were there. So our health system was not able to sustain it, but we have learned from that. And now so many oxygen generation plant, I think at the district level also, in all the districts of the country, we have oxygen generation plants. So the health system has been strengthened immensely after the second wave of the pandemic. Thank you.
Thank you. As I'm running short of time now, it's exceeded 15 minutes. Sorry for other two colleagues, I can see still. You can only ask the question, and I will request Dr. Shabnam to sum up the thing before we go into the conclusion.
Sure. So there has been a tremendous response, a very excellent response from the industry towards the COVID vaccination. Not just the COVID vaccination, but the other areas during the pandemic situation. One of the very the leading question is towards the public health, towards education also. And here the theme is also that leaving no one behind. We are working for the migrant population. And the tracking is the very big issue among for the public health. I understand that the industry doesn't have a responsibility towards public health, public education issue, but still, like Amazon, the Swiggy, they ensure that their service providers should be 100% vaccinated, both one and the second doses also. How do industry ensure that their workforce, the migrant workforce, for example, the manufacturing industries, Maruti does have a loyal truck drivers and so on. How do you ensure that these migrant workers, the floating population, you ensure first, second, and the third doses?
And I would take the final question as well, and together.
Can you hear me okay?
Please.
Yeah, Abhinav from NCER. Quick question to the speaker from CII. I was interested in your comment about the future of pandemics being not once in 100 years, but maybe 3 to 5 years. Intuitively, it makes sense, in a global connected world, etc. But as a possibility, it makes sense. But so could you expand a bit more about your thinking on that? And also, how do you balance, so someone mentioned the oxygen capacity generation and hospitals. How do you manage balancing the over-investing versus that?
Right. I'll try and summarize everything, Amit, in 1 minute, addressing what the lady in the green jacket also said. There's not a single country in this world which has managed the pandemic. The very fact that you have a pandemic is unmanageable. That's the basis of the pandemic. That's why it happens worldwide. That's point number one. Point number two, no matter what you do, and here I'm wearing a clinician hat, right? I'm a clinician primarily. In any emergent situation, when there is a zoonotic disease transcending to human beings, you learn on the job. There is no precedence. There is no precedence. There is no SOP. There is nothing out there anywhere in the world to guide you to do what you have to do. So you've got to understand, absorb it. The turnaround time for the vaccines to be produced is unheard of. And why was it so? Because vaccine development and research, 15 to 17 years with the Ebola virus, transformed itself into utilization patterns. That's the next one. To your point, will pandemics shorten? Absolutely. Why? Look at the way we are expanding. There are enough people from UNDP to substantiate what I'm saying about the growth of cities, right? So till we don't become more responsible as human beings, this is going to happen because you are moving and shifting populations of animals, getting closer to them, displacing them, so on and so forth. So this is going to happen. And a very interesting point, if you read Nature, every part of our human body, the DNA, is embedded with molecules of particles from viruses. This is who we are, right? We don't acknowledge it, but this is who we are. We learn to live with each other. Lastly, what does industry do today? Today, the most important thing for a board is ESG. Right? It is a boardroom agenda, it's a boardroom deliverable, it's a boardroom KRA. And that includes what you do with your contract laborer, which in turn addresses migrant workers. From an insurance perspective, we are working very, very hard to see what we call a part, which is called the missing middle. How do you engage with the missing middle to have a social network to be able to make it happen? Everybody on this panel is working with it. So these are various places, very difficult to finish in 1 minute, but yes, I can assure you there is recognition, work, commitment from the industry to address it. Back to you.
Thank you, madam. And I know there is a sort of more time required to answer all these questions. And I also agree, India, if I see India is a big success. And whenever we take initiative, gaps are always there. We learn from that. That's a learning process. And then we again start back to the boardroom to work on those gaps and start again from the scratch to address those problems. And that's why the session is meant for networking. It is meant for encouraging platforms to come together, different stakeholders to come together. And that's what the SDG also says. The goal number 17 is also somehow is indicating to come together and work together as a team to address the problem. With this statement, I would hand over my mic to the chair to sum up the session and conclude it. Thank you.
Thanks, Amit, and thank you all the panelists for their contributions. I think 3 takeaways, if I may mention. One is, of course, the private sector has been an uncompromisable, part of the solution to address vaccination, since the focus of this discussion has been vaccination all through the day. Their efforts have actually helped India achieve the scale of vaccination, so that has to be acknowledged and applauded. And I guess that has been sufficiently done. It also, another point that came across all the presentations was that this really is a multi-stakeholder effort. Everyone comes together, not even doing individually what each other does, but actually doesn't sync with the other, because that's where then the multi-stakeholder really sort of works, otherwise it doesn't work. So that coming into synchronization is very important. The third one is the missing voice here. We are still using the employers or the private sector as one homogeneous group, which is not the case. We did talk a little bit about 90% of the workforce in the informal sector, but the point really is that we are not listening to their voices. Yes, the informal sector, the small and the medium enterprises in the formal sector, they have also done their bit and tried to achieve large scale of vaccinations. But if you remove vaccinations for a minute from the conversation and focus on the larger the COVID pandemic challenge, then you see many more fault lines. And my own observation is that we've not addressed those fault lines because the success of vaccination is actually overshadowing, those fault lines. So, next time we have another crisis which affects the large informal migrant workers, things are going to collapse like a pack of cards. On that relatively sad note, let me conclude this session, but congratulations to everyone for their work and the contributions that you made. Thank you. Bye-bye.
Okay, before you leave the dais, I would request my colleagues to extend a small token from our colleagues.
Thank you, Mr. Joshi. Thank you, Mr. Chaudhary. And thanks, of course, to all of our panelists. Today has been an incredibly rich discussion with lots for each of us to reflect on and perhaps even incorporate in our work going forward. To close this packed day of insights, I'd like to request Mr. Sanjay Avasthi, Head of Office IOM, to please make the closing remarks and offer a vote of thanks. Mr. Avasthi.
Good evening, everybody. On behalf of the International Organization for Migration, may I take this opportunity to thank our distinguished speakers from the state governments, migration experts and practitioners for presenting their thoughts and analysis on the crucial issue today. I would also like to thank our chairs and moderators for skillfully coordinating the discourse over the day. And our gratitude also goes to Mr. Govind, Ms. Kritika, and Ms. Saudamini, and the entire purpose team for their support in organizing this event and this entire preparatory process. And how can I forget Dr. Sanjay Kumar and Mr. Shivendra Singh from UNFPA, who were an integral part of this whole initiative, and also for their help in finalizing the report. And then the India Migration Now team for the data collection and field work for this report. And Rajan and the team for providing excellent technical assistance, which went without any challenges. Let me also, my friends, take this opportunity to express my gratitude to Mr. Shombi Sharp, the UN Resident Coordinator, and Dr. Muni Raju, Deputy Advisor Niti, and Dr. Pal from Ministry of Women and Child Development for your critical insights and encouragement. And my sincerest thanks to our invitees for their vital interventions for such active participation. It could not have been so lively without your very insightful questions and conversations. I believe today's deliberations have been fruitful and will contribute towards developing a better understanding of the ground realities related to the migrant workforce. Let me assure you of IOM's commitment to these collective efforts, and we look to your involvement and participation in our future initiatives as well. With these words, I wish you a wonderful evening, and please don't forget to have some tea and coffee and some savories which have been placed outside before you go. Thank you once again.